So what we're going to do is we're going to do a live discussion on each topic. Let's say, I'll give an example. On September 1st, imagine that we're going to do anatomy, okay? So we are going to do anatomy from morning around 8:39 to evening 6:37 in 2 sessions. The morning will be the live discussion of all the questions of these high-heeled, hot competency areas of INI-CET going in depth. And then we'll stop it by evening, around 2 more hours left as a second session, where we'll take all the images alone in asked in the last 5 years in INI-CET and the entire subject together and discuss the images alone to give you a focus on image-based questions and the applications around these topics. So it will be 2 parts in the bootcamp. One is the hardcore competency review of the entire subject, connecting you to each and every topic, and then a second smaller session of discussing all the images of the particular subject. Understood? So that is what is done on the day 1, and then you'll get 2 days to study. Like after first day anatomy, 2 days to revise, or 1 day to revise anatomy by yourself from your primary notes, so that you can make sure that you get the 130 base correct. Understood? If not, studying this high yield area alone will never get you INI-CET. You have to make your fundamentals and basics strong and revise everything up. It's very, very important. Understood? So you do that 1 day revision, and then you write the anatomy exam on the second day evening in the Medico app. And the next day, let's say if it is dermatology, 1 day dermatology, same thing. Morning the competency review topic question discussion, evening the image-based question discussion. Next day, time for you to study by yourself, evening exam. Then it's 2 days medicine. 2 days we'll discuss all the systems like this. Morning you will discuss the competency review topics. After that, evening image discussions. 2 to 3 days holiday, and third day evening exam. So that you are having a revision track to come back to your original notes, understand these are the areas to study, focus and learn more or go deeper. Also review a quick review of all the images and topics in the subject, and making sure you touch your base notes completely, so that you're going to improve from week on week. So how do we assess that? Every week there will be an INI-CET mock test happening in Medico app, which you can come in and take, so that you will understand your score is improving or not.
Hi, hello, dear students. I am Dr. Rohita, your faculty from Medico. I welcome you all to this revision session on microbiology as a prelude to INI-CET, which is due in November. Let us use this session to quickly revise the key topics in microbiology. Without wasting much time, let us directly go into the question and answer session. So let's start with the very first question. A 65-year-old woman is admitted to the hospital with signs of sepsis, including high fever, hypotension, and altered mental status. Blood cultures are taken, and the lab reports that the isolated bacteria are gram-negative rods that are oxidase negative and ferment lactose. The patient's condition is rapidly deteriorating, and antibiotic therapy is initiated. Which component of the bacterial cell structure is most likely responsible for the patient's severe systemic inflammatory response? Let's see what the options are. Option A, peptidoglycan, B, lipopolysaccharide, C, teichoic acid, and D, flagellum. So one thing that I want you all to remember is every single word in the question has to be read with utmost concentration, and then you have to zero in on what are the key points that the question is trying to tell you. So here they have taken you on a detailed discussion on the signs and symptoms of a lady who has sepsis with high fever, hypotension, and altered mental status. So these are definitively signs of sepsis. Okay. And the lab has also, there's a bacteriological confirmation also, gram negative has been grown, and they are oxidase negative and they ferment lactose. So you have an isolate also there. Condition is deteriorating. So in 2 words, how would you describe this condition? This patient is showing all the signs and symptoms of being in endotoxic shock. So, which is that component of the bacterial cell wall that is responsible for causing endotoxic shock? That is the question. Is it peptidoglycan or lipopolysaccharide or teichoic acid or flagellum? So, endotoxic shock is a feature of gram-negative sepsis, and the component which is responsible for it is not flagellum. Flagellum is involved in motility. Is not teichoic acid, because teichoic acid is not seen in gram-negative. And it's not peptidoglycan also, because peptidoglycan actually gives only structural integrity and it's very less in gram negative. So the component here is lipopolysaccharide. Let's use this question, let's use this question to quickly discuss the difference between the gram negative and gram positive cell wall. So this is the image of a gram negative cell wall. Here you can see that here there is a periplasmic space. Okay, and the peptidoglycan layer of the gram negative cell wall is lying within the periplasmic space. You can see this blue structure here. This is the peptidoglycan cell wall. It's very thin. It's only around 2 nanometers in thickness. And outside the peptidoglycan layer, there are 2 other layers lying outside. So outside the peptidoglycan layer means the first layer is the outer membrane and the second one is the lipopolysaccharide. Okay, so there is an outer membrane here, and then anything that you see beyond that is the lipopolysaccharide layer. Okay. So now remember that image. Okay. So the peptidoglycan layer, I told you, it is very, very thin, 2 nanometers or even less. And it's made up of N-acetylmuramic acid and N-acetylglucosamine. Okay. So N-acetylmuramic acid and N-acetylglucosamine. And it's got something called as tetrapeptide side chains. These side chains are cross-linking the muramic acid and glucosamine. And these side chains are linked to each other by means of covalent bridges. So we are discussing gram negative. Okay, so covalent bridges are responsible for linking the tetrapeptide side chains, and the basic building block is NAMA and N-acetylglucosamine. Now, like we mentioned, there is an outer membrane, that is a phospholipid layer that you get to see there as the outer membrane, and there are various outer membrane proteins that act as porin proteins. What are porin proteins? They actually help in the transport of substances across the cell wall. Then comes the lipopolysaccharide layer that is only seen in gram negative, and it's got 3 components. Lipopolysaccharide. So the first component is lipid A. The lipid A component is the endotoxin, and that is responsible for all the features of endotoxic shock. Now in this question, the patient has fever, hypotension, and all these are features of endotoxic shock which are mediated through cytokines, and there will also be multi-organ failure. So lipid A component is the endotoxin. Then polysaccharide, you've got a core polysaccharide layer, yes. And still outside that, you've got an O antigen or an O side chain, which is the major antigenic component of gram negative. And that is the one which is used for serotyping. So once again, let me take you to the picture here. Now, can you make out? This is the lipopolysaccharide layer that you see. The pink one is a lipopolysaccharide layer. There is a lipid A component which you can see there. Okay, this is lipid A, that is the endotoxin. Then there is the polysaccharide part, and still outside that there is the O antigen. Okay, so this is what is responsible for endotoxic shock. And also there is a periplasmic space. I showed you that in the beginning here. This is the periplasmic space, and the peptidoglycan layer is actually lying in the periplasmic space. So this unique structure of gram-negative cell wall is also responsible for the way it stains on gram staining. We know that gram-negative will be staining as pink. So why not violet? Why is it pink? So that feature is also because of the same reason. That is, the gram-negative bacteria, they get decolorized easily. Why? There are 3 reasons for this. One is the outermost, you've got a lipopolysaccharide layer. So the lipopolysaccharide layer means it's lipid rich and an organic solvent like acetone can quickly dissolve it. Then you already saw the peptidoglycan cell, the peptidoglycan layer of the cell wall is too thin, so it will get decolorized very fast, okay? It will be very permeable. And still further inside, the protoplasm of gram-negative is less acidic compared to the gram-positive. So the dye, the basic dye, the crystal violet will not bind to it with as much affinity as it does to a gram-positive. So these are the three basic reasons why gram-negative appears pink. So gram-negative has got lipopolysaccharide. The organic solvent will dissolve it. It's got a very thin peptidoglycan layer, so it's very permeable. And the protoplasm is less acidic compared to the gram-positive. Now that we spoke so much about gram-negative, we should also discuss a little bit about the gram-positive cell wall, isn't it? So this is the structure of a gram-positive cell wall. Just look at it. It's so uncomplicated compared to a gram-negative. So here, look at the peptidoglycan layer. Okay, it's so much thicker. It's about 15 to even 80 nanometers thick. And it's got a unique component here, which is called as a teichoic acid, which is seen only in gram-positive cell wall. The gram-negative cell wall has got the lipopolysaccharide. Gram-positive has teichoic acid. Now, this is the structure of a gram-positive cell wall. Again, N-acetylmuramic acid and N-acetylglucosamine bound together by tetrapeptide side chains. They bring about cross-linking. And these side chains are linked by a pentaglycine cross-link. This pentaglycine cross-link is not seen in gram-negative. That is where I told you there are covalent bridges. So now I hope you understood the difference between gram-negative and gram-positive. Okay, much thicker peptidoglycan, teichoic acid and pentaglycine cross-linking is seen for gram-positive cell wall. And this has also been included in a table format. So this is gram-negative versus gram-positive. Now you know peptidoglycan, how much thicker it is, 15 to 80 nanometers compared to gram-negative, which is 2 nanometers. Now pentaglycine bridges are seen in gram-positive. Lipid content is very less in gram-positive compared to gram-negative. Lipopolysaccharide is seen only in gram-negative. Teichoic acid is seen only in gram-positive. Positive teichoic acid. Okay, now you can remember that. Amino acids are few in gram-positive compared to gram-negative, and aromatic amino acids are present only in gram-negative. So if you make it a table like this, you will be able to understand the differences between gram-negative and gram-positive. Okay. Then the other options we already discussed. Now you know peptidoglycan is for structural integrity and flagellum is for motility. Endotoxic shock is due to lipopolysaccharide, which is seen only in gram-negative. Okay. So now I think you're clear with that question. Now let's go to the next one. A 60-year-old patient with a history of chronic obstructive pulmonary disease or COPD presents with fever, productive cough and shortness of breath. A sputum sample is collected and Pseudomonas aeruginosa is identified as the causative organism. Pseudomonas aeruginosa is known for its ability to thrive in various environments due to its versatile metabolic capabilities. The laboratory decides to culture the bacteria under specific conditions to evaluate its growth characteristics. Which of the following growth conditions is most appropriate for culturing Pseudomonas aeruginosa and assessing its metabolic activity? Now, one thing I've noticed is all these questions will begin from somewhere and it will end in a totally different place. So clinically they have said that the patient has COPD, okay, he's coming with some symptoms like fever, productive cough, and Pseudomonas is the organism that has been isolated, okay, and the laboratory now decides to see whether, how to grow it under specific conditions so that the growth characteristics can be evaluated. Now comes the crux. Which one of the following growth conditions is most appropriate for culturing Pseudomonas aeruginosa and assessing its metabolic activity? So which is the most appropriate means that more than one situations could help in growth, but that which helps to assess it best, okay, giving it the best and getting the best out of it Is it an anaerobic environment with a glucose-rich medium? Or option B, aerobic environment with minimal medium supplemented with glucose, microaerophilic environment with nutrient agar, or aerobic environment with nutrient-rich medium. So Pseudomonas is an organism which can grow in more than one of these options, but which is the most appropriate to assess its metabolic activity? Is it anaerobic anaerobic environment with glucose rich? No. Pseudomonas is a obligate aerobic organism. So it cannot grow in an anaerobic environment at all. So that option is out. Aerobic environment with minimal medium supplemented with glucose, yes, it will grow. But you want to assess its metabolic activity and give it the best, then this is not the best option, okay, because you're giving very little. So it will not be able to show its full potential. Microaerophilic environment, no, microaerophilic is not the optimum environment for Pseudomonas. There are other organisms which are microaerophilic, but Pseudomonas is not one of them. But an aerobic environment with nutrient-rich medium, yes, definitely that will help to express the full metabolic potential of Pseudomonas. So how do you classify organisms based on their oxygen requirement? So based on their oxygen requirement, organisms are categorized into microaerophilic, obligate aerobes, obligate anaerobes, and facultative anaerobes. Okay. So microaerophilic means they require small quantities of oxygen, about 5 to 10% for their growth. And that is Helicobacter and Campylobacter. So these are the microaerophilic organisms. Obligate aerobes means they are obligate. They need O. They need oxygen for their growth. So they are obligate aerobes. They will grow only in the presence of oxygen. And that is Pseudomonas, Mycobacterium tuberculosis, Vibrio, and such other organisms. Obligate anaerobes means that they are 100% anaerobes. They cannot grow in the presence of oxygen. Example is bacteroids and Clostridium tetani. And facultative anaerobes, most medically important bacteria fall under this class. That is, they are aerobes, but they can also grow in anaerobic environment. So facultative anaerobes are E. coli, Staph aureus, and so on. Okay. So when you say facultative anaerobes, they are aerobes that can grow in anaerobic environment as well. Okay. So what are the reasons why we ruled out the different options? We have already discussed. It is an obligate aerobe. So you can't grow it in anaerobic medium. You cannot grow it in microaerophilic. It's not ideal. You cannot grow it in aerobic with minimal supplementation. Even that also is not ideal to demonstrate its full metabolic capabilities. So like I said, every question has that key one or two words from which you will be able to pick out what is it that is exactly being asked for. Now coming to the next question. A 35-year-old woman presents to the emergency department with a 2-day history of severe abdominal pain, nausea, vomiting and diarrhea. She mentions that she attended a large outdoor picnic 2 days ago where she consumed various foods including a potato salad. On examination, she is febrile and has tenderness in the lower abdomen. Stool cultures reveal the presence of Shigella dysenteriae. Which of the following mechanisms is primarily responsible for the pathogenicity of Shigella dysenteriae in this patient? Okay, so it's a woman who gives a very short history, maybe a 2-day history of abdominal pain, nausea, vomiting, and diarrhea. So you know one thing, she's got some food poisoning because she's gone on a picnic and she has eaten a potato salad. So that is from where she's getting the symptoms. And when you examine her also, she's febrile and she's got pain, tenderness in the lower abdomen. And the stool cultures have already revealed Shigella dysenteriae. So now, what is the primary mechanism for the pathogenicity of Shigella dysenteriae? That is the question. Every question that comes involving Shigella, there is just one word when you look at the pathogenesis that you have to pick if you want your answer to be 100% correct. So what is it? Is it a production of a heat-stable enterotoxin? Or is it invasion of the intestinal epithelial cells, colonization and biofilm formation in the gastrointestinal tract? or production of urease leading to ammonia production. So like I said, when you see a question about the pathogenesis of shigellosis, you have to close your eyes and you have to mark only one answer, which is the reason for all the problems associated with shigellosis. What is that? It is invasion of intestinal epithelial cells. So shigellosis is equal to invasiveness. So that is the thing about Shigella. It's a highly invasive organism. It's not production of a heat stable enterotoxin. There are other pathogens for that, like maybe enterohemorrhagic E. coli and all that's producing. For heat stable enterotoxin, it's E. coli. Then colonization and biofilm formation, that's not the reason. Urease production is also not the reason. So let's have a look at the pathogenesis of shigellosis. So here you can see in this image, this is Shigella. Okay. So how is it getting inside? Invasion is via the M cells. Okay. M cells are the ones that are responsible, and are the primary cells that is involved in the invasion of Shigella. And it is because of the presence of a plasmid. Okay. Invasion is due to the presence of this plasmid. Okay. VMA. Then macrophages. So once what happens is that once the Shigella has entered, now this is the M cell and it's gotten inside. So once it has entered the M cell, it is activating the macrophages. So the macrophages are getting activated and they are engulfing the bacteria and they are processing it and presenting it and resulting in the involvement of numerous other inflammatory cells. So which are the inflammatory cells which are getting recruited? These are, there are T cells, dendritic cells, B cells and PMNLs, that is polymorphonuclear cells, it is a neutrophil. So these four categories of cells get activated when the antigen, that is Shigella, is processed and presented by the macrophages. So the first step is the invasion, then it is engulfed by the macrophages and then the inflammatory cells get recruited and there will be release of cytokines. Okay, so these are the four cells, your T cells, B cells, dendritic cells and the polymorphonuclear neutrophils. Now besides this, what happens is that these Shigella are also capable of direct cell to cell spread. Here you can see that from one cell it's moving to the other, that is by means of actin polymerization. Then this Shigella also has both exo and endotoxins. The exotoxins that is produced by Shigella is SHET1 and 2, that is produced mainly by Shigella flexneri, and Shiga toxin that is produced by Shigella dysentery type 1. So these are the two types of exotoxins produced by Shigella. And endotoxins are responsible for inflammation and mucosal ulceration. So these are all key components in the pathogenesis of shigellosis. So once again, just have a look at this image here. It is coming and entering via the M cells because of the presence of a plasmid, that is the VMA. And once it gets into this, it will result in activation of the macrophages. The macrophages will engulf it and will release it, resulting in recruitment of various inflammatory cells like B cells, T cells, dendritic cells and neutrophils. And there will be subsequent production of cytokines. Besides this, there is also direct cell-to-cell spread by means of actin polymerization, and it produces exo and endotoxins. The exotoxin produced by Shigella dysentery type 1 is called the Shiga toxin, and that which is produced by Shigella flexneri is called SHET1 and 2. Now, a little bit more about Shigella. It is the most important agent causing bacillary dysentery, yes. And all around the world, Shigella soni is the most commonly seen species. But in India, it is Shigella flexneri. Transmission has got 5F, that is fluids, fomite, feces, food and fingers, of which the most common is fingers. Okay, so the most common is fingers and the others are fluid, fomite, food and flies. Okay, now and flies. So when I say fingers, you can also include it as feces because the hand contamination is coming from the fecal-oral. Okay, and that is how it is resulting in the spread of infection. So these are the different methods of transmission. So you can have fomites, you can have vectors like flies, all these are involved. Now when you look at the infective dose, it is 10 to 100 bacilli. So very small load of infective dose there. It is very similar to enterohemorrhagic E. coli, Giardia and Entamoeba histolytica. Then some more differences between the different Shigella. You've got Shigella dysentery, flexneri, boydii and soni that form group A B, C and D. Now the only mannitol non-fermenting one is group A. All the others are mannitol fermenting and catalase positive. In group A, there are about 15 serotypes, of which the serotype 1, that is Shigella dysentery type 1, otherwise known as Shigella shige, is the only one that is catalase negative, and it's also the only Shigella to produce the Shiga toxin. So catalase negative is Shigella dysentery type 1. It's also indole negative and it produces a Shigella toxin, that's a Shiga toxin. It's basically a cytotoxin that acts by inhibiting the protein synthesis. Then serotype 2 is SMITC, that is indole positive, and 3 to 7 is known as the large sacs group. Okay, so from this one you just have to primarily remember Shigella dysentery type 1. What makes it different? All the dysentery types are mannitol non-fermenting. This is catalase and indole negative as well, produces the Shiga toxin. Then the next one is Shigella flexneri. There are 8 serotypes, okay, and of which serotype 8 has got 3 biotypes as well. That is Manchester, Newcastle and Boyd 88. And we already mentioned that SHET1 and 2 are exotoxins produced by the Shigella, okay. So that is a toxin that's produced. Then group C is got Shigella boydii, that has got 19 serotypes, and D has got just one serotype, 26 colicin types, and it is the only late lactose fermenting. All the others are non-lactose fermenting. This is also non-lactose fermenting. This too is non-lactose fermenting, but the only one that is late lactose fermenting is Shigella soni, okay, and its ornithine decarboxylase positive as well. So heat stable enterotoxin, we already said it's produced by E. coli, that is enterotoxigenic E. coli, that ETEC is the one that produces, it's not Shigella. Colonization biofilm formation is a method of pathogenesis of an organism like Pseudomonas. It does not have anything to do with Shigella, and urease production, we all know it is H. pylori that causes that. It's got nothing to do with Shigella, okay? Then coming to the next question, let's discuss a question about sterilization. A hospital is preparing surgical instruments for use in an upcoming procedure. To ensure that the instruments are completely free of all microorganisms, including bacterial spores, they must undergo a proper sterilization process. The sterilization is performed in an autoclave. Which of the following steps is essential to ensure effective sterilization in an autoclave? Ensure that the instruments are dry before loading them into the autoclave. Use ethylene oxide gas in the autoclave chamber. Maintain the temperature at 121 degrees centigrade and pressure at 15 psi for at least 15 minutes. Immerse the instrument in 70% ethanol before autoclaving. So this is a surgical instrument. You want it to be free of all microorganisms including spores, which is why you have chosen autoclaving. Now, which of these is the correct answer when it comes to ensuring effective sterilization in an autoclave? Ensure that the instruments are dry before loading them. It is good if the instruments are dry, but it's not necessary that they should be, because autoclave itself is using steam. But you should definitely ensure that the instruments are dry or the set is dry when you're unloading it from the autoclave. If it is wet, that means the sterilization process has not happened well. So that is not the right answer. Use ethylene oxide gas. Why would you use ethylene oxide gas in an autoclave chamber? It is steam under pressure, right? Ethylene oxide gas is used in ETO sterilization, so that is wrong. Maintain the temperature at 121 degrees centigrade and pressure at 15 psi for at least 15 minutes. Yes, that is the most commonly used holding time, 121 for 15 minutes at 15 psi. So that is the right answer. Immerse the instrument in 70% ethanol. You don't have to do anything prior to autoclaving except making sure that the set is clean. Only that which is clean will become sterile. So it has to be clean, yes, but no other disinfection or sterilization procedure need to be undertaken prior to autoclaving. Okay. So this we have already discussed. So The standard protocol basically involves, like we discussed, 121 degrees for 15 minutes at 15 psi. And steam is definitely the preferred method for all instruments that are not heat sensitive and not sensitive to the other parameters like pressure, steam, moisture, etc. For all medical and surgical instruments, it is definitely the go-to sterilization process, no doubt, no matter what comes after that or what specialized types of sterilization happens, but the best is always steam. Now, what is the mechanism of action? It is denaturation and coagulation of protein. This is something you have to remember. Okay, denaturation and coagulation of protein. And there are various holding times. Besides 121 at 15 minutes for 15 psi, which is the most commonly used one, there is also 126 for 10 minutes at 20 psi and 134 for 3 minutes at 30 psi. So you must remember, as the time comes down, the pressure goes on increasing. So 121 for 15 minutes at 15 psi, 126 for 10 minutes at 20 psi, 134 for 3 minutes at 30 psi. So these are the different holding temperatures. Okay, I want you guys to learn this up properly. Then you know that it's mainly used for a variety of surgical instruments, okay? Culture media, laboratory samples, biomedical waste, pipettes, even some liquid solutions and water, all of them can be sterilized by autoclaving. And already we mentioned biomedical waste, so and paraffin, dusting powder, all these will go into the autoclave. Okay, pipette tips, glassware which can be autoclaved, you can use this. And what is the sterilization control? It is Geobacillus stearothermophilus. That is the sterilization control of an autoclave. Now, since we mentioned that autoclave is acting as a sporicidal agent, which are the other sporicidal agents that also I have included in this discussion? So, sporicidal agents using heat is autoclave, hot air oven, and incinerator. Then you've got some other chemical substances that can be used. TO, plasma sterilization, hydrogen peroxide, peracetic acid. All these can be used for as sporicidal agents. Okay, so you've got autoclave, then you've got hot air oven and incineration, then plasma sterilization, ETO, peracetic acid, hydrogen peroxide, and aldehydes. These are the commonly used sporicidal agents. So remember, 121, 15 minutes at 15 psi is just one holding temperature. You've got 126 for 10 minutes at 20 and 134 for 3 minutes at 30. And another thing that you should remember is it's the preferred agent for anything that is heat tolerant. Then comes another question about disinfection. Okay. A hospital is implementing enhanced disinfection protocols in an ICU to control the spread of nosocomial infections. The infection control team decides to use a disinfectant that is effective against a wide range of pathogens, including bacteria, viruses, and spores. The team selects a chemical disinfectant known for its broad spectrum activity. The following image shows a bottle of the chosen disinfectant used for cleaning surfaces in the ICU. Okay, so it is something which can target a wide range of spores, but may not be 100% sporicidal like the ones which we discussed, but it can cover a wide range of bacteria, viruses, and spores. And that is the agent which they have chosen, which is that it is sodium hypochlorite. Now comes the question, which of the following best describes the mechanism of action of the disinfectant shown in the image? So what is the mechanism of action? Does it disrupt the bacterial cell wall synthesis? Does it cause denaturation of proteins and amino acids? Inhibition of ribosomal protein synthesis? Or interference with DNA replication and repair? Okay, so which of these could it be? So most of the disinfectants that we know, they act through a very common mechanism, which is denaturation of proteins and amine and nucleic acid. So it will bring about denaturation of the cellular components, and that is how it normally acts. All the other options that are given are more in keeping with the action of certain antibiotics than disinfectants. So sodium hypochlorite acts by denaturation of proteins and nucleic acid. Let's have a look at the discussion. So the one that we saw here is sodium hypochlorite. It's otherwise known as bleach or even as household bleach. It's a very powerful oxidizing agent. It will denature proteins and nucleic acid, and thereby it will cause a disruption in the structure and function of the cellular components, leading to cell death. Okay, so that's how it causes. It's an oxidizing agent. It denatures proteins and nucleic acids. So the cellular components will lose their structure and function, and subsequently there will be cell death. It's very effective, like we mentioned, against a wide range of bacteria, viruses, fungi, and even certain spores. Now, what is the active component of bleaching powder or sodium hypochlorite? It is hypochlorous acid. From this hypochlorous acid, free chlorine will be released, and free chlorine is what is responsible for the microbicidal activity. And spill management, it is one of the most commonly used agents for spill management. 5% sodium hypochlorite is the concentration of the parent solution usually, but the concentration at which it is used to manage a spill is either 0.05%, that is 1 in 100 dilution for a small spill, or 0.5%, that is 1 in 10 dilution for a large spill. And the normal contact time that is given is 20 minutes, and that's only given for a large spill. So if it's a small spill, you will just use a 0.05% or a 1 in 100 dilution of 5% and wipe it away. No contact time. In a case of a large spill, it's 0.5%, that is 1 in 10 dilution of 5%, and you give a 20-minute contact time. And why do we do that? This is to prevent infection due to bloodborne viruses, that is HIV, hepatitis B, and hepatitis C. Okay, active component is hypochlorous acid, and that is the one that is releasing the free chlorine, which is responsible for the microbicidal activity. Then, like I said, the other options are mainly with regard to antibiotics. So disruption of the bacterial cell wall is usually seen with beta-lactam antibiotics. Then ribosomal protein synthesis inhibition is seen with tetracyclines and aminoglycosides. And DNA replication inhibition is usually a function of fluoroquinolone. So these are the different mechanism of action of antibiotics. But for most disinfections, it's denaturation of proteins and nucleic acids. Okay. Then, next question. A 65-year-old diabetic man presents with a non-healing ulcer on his foot. The wound is draining purulent material, and the physician suspects a polymicrobial infection. A sample of the wound exudate is collected and sent to the microbiology laboratory for culture. The lab technologist inoculates a sample into different culture media to isolate the potential pathogen use. Which of the following culture media is most appropriate for isolating anaerobic bacteria from the wound sample? Okay, so this is a case of a diabetic non-healing ulcer. There is purulent material coming, clinician thinks it's polymicrobial, sends it to the lab, and you are inoculating it into different culture media. And which of the following is most appropriate for isolating anaerobic? Is it McConkey agar? Is it blood agar in an anaerobic jar, Sabro's dextrose agar, or Theomartin agar? Okay. So two options. It is McConkey agar is definitely not preferred for anaerobes. It's a differential media that mainly differentiates into lactose fermenting and non-lactose fermenting media, and is also a low selective media. So that is definitely out. It's got nothing to do with anaerobes. Then what about Sabro's dextrose agar? That is mainly used for fungi. For fungal infections it is used. It's got nothing to do with anaerobic bacteria. Theomartin agar is, yes, used for a certain group of anaerobes, that is Neisseria gonorrhea and Neisseria meningitidis. When you want to isolate it from clinical samples, then it is used, but otherwise you cannot be using it for this particular condition. Here the best option would be blood agar in an anaerobic jar. So that's such a simple thing, isn't it? To grow anaerobes, you just need blood agar in an anaerobic jar. No fancy names there. So there are various methods to create anaerobiasis, and one is the Macintosh Fields jar, which was previously being used. I've included an image of the Macintosh Fields jar. I'm sure that all of you would have seen this. Okay. So this was what was earlier days used to create anaerobiasis. Okay, it's a physical method wherein you're removing the oxygen and you're trying to create anaerobiasis. Then there's something called as an anoxomat. Okay, anoxomat is what you're doing is an automated thing. It will be sucking out the oxygen, and it will be pulling out the oxygen, and it will be pushing in hydrogen gas. So hydrogen gas is what is normally being pushed into this, and that is how an environment of anaerobiasis is created. Then there are chemical methods, and the classical one is the gas pack. Okay, so this is the gas pack method, in which you've got these blood agar plates, and you're using gas pack, which mainly consists of sodium borohydride and sodium bicarbonate. That is what is being used to create an anaerobic environment. And the indicator which is used here is methylene blue. Okay, this is the indicator. Anaerobic methylene blue is the indicator. So depending upon whether there is anaerobiasis or not, you will be able to find the blue color. So this is another method, a chemical method. So Macintosh fields and anoxomat were physical, whereas gas pack is a chemical method. Then you also have other methods like an anaerobic glove box and an anaerobic station. So you can see in this image is an anaerobic workstation, absolutely no air entry inside, and there also you can do your work and you can place the plates. You can also use some reducing agents like thioglycolates and RCM media. They can also be used. And blood agar is an excellent media for growing anaerobes. It's really a good media. Only thing is that you have to provide the subsequent anaerobic environment. Okay. So McConkey we mentioned, Sabrods we mentioned, and Thea Martin also we said is a selective medium. Okay, it cannot be considered to be an anaerobic medium per se, it's more selective. Next question. A 60-year-old woman with a history of recurrent urinary tract infections presents with dysuria, urgency, and fever. A urine culture is obtained and E. coli is identified as the causative organism. The initial antibiotic therapy with ciprofloxacin was started, but the patient's symptoms persist. The laboratory report later indicates that the E. coli isolate is resistant to ciprofloxacin and multiple other antibiotics including ampicillin and trimethoprim sulfamethoxazole. The organism is found to produce an enzyme that hydrolyzes and inactivates a broad range of beta-lactam compounds. Which of the following mechanisms of resistance is most likely responsible for the failure of antibiotic therapy in this patient? Okay, so you have a 60-year-old woman, recurrent urinary tract infections, organism being E. coli, who was empirically put on ciprofloxacin, but later when the report came, she is resistant to ciprofloxacin and ampicillin and cotrimoxazole, and has got an enzyme that inactivates a broad range of beta-lactam compounds as well. So, which is the one that is most likely responsible for failure of antibiotic therapy? So, if there is going to be a failure, which is that particular mechanism of resistance that is responsible? Is it efflux pump overexpression, beta-lactamase production, altered penicillin binding proteins, or methylation of ribosomal RNA? So here it is very clear that they have already said that there is resistance to multiple antibiotics. But one unique thing that they also noticed was it has an enzyme that produces and inactivates a broad range of, that hydrolyzes and inactivates a broad range of beta-lactam compounds. And what is that mechanism of responsible that is most likely to result in failure? Now, altered penicillin binding proteins is definitely not the answer. Why? Because this is seen in MRSA. It's gram positive. Here it is E. coli. Then methylation of ribosomal RNAs is usually a mechanism of resistance which is seen in macrolides, and that again is not involved in the discussion here. Then it already said that there is an enzyme that is responsible for the inactivation. So the most likely factor would be beta-lactamase production. And efflux pump overexpression is also seen, but that is normally responsible for resistance to tetracyclines and not to sulfonamides and quinolones. It's more to do with tetracycline resistance, and it's commonly seen more in Pseudomonas, also in E. coli. So here again, this is also not the right option. So one point that I want you to remember, that the major mechanism of resistance in gram negatives is because of the production of beta lactamases. Now if you will recollect the gram negative cell wall image, in the periplasmic space where you saw the peptidoglycan thin layer line, that is where a number of gram negative beta lactamases are present. Okay, and as the drug tries to enter itself, it will be inactivated by these beta lactamases. So what are the different classifications of beta lactamases? That is what we are going to discuss in this question. So beta lactamases, there are 4 classes: class A, class B, class C and class D as per the Ambler classification. Okay. Now, the Ambler classification is usually based on what is the active moiety. Is it serine or is it zinc? So, serine containing beta lactamases are present in class A, class C and class D, whereas the zinc or the metallo-beta lactamases belong to class B. Now, there are numerous beta lactamases that come under class A, B, C and D, but I will tell you which are the important ones that you need to remember. Now, class A beta lactamases could be narrow spectrum, extended spectrum or carbapenemases. Okay. So, narrow spectrum are usually the TEM1 and the SHV1. The extended spectrum are SHV2 and CTXM. But remember, the class A carbapenemase is KPC. This name KPC1 you should remember. Then coming to the class B. Class B, we said it is a metallo-beta lactamase. There are various ones that come under this. It has got only carbapenemases are there in class B, and that is IMP, VIM and NDM. Remember the name NDM. Class C are the cephalosporinases, okay, and the prototype for class C will be AMC. And class D has got oxacillinases. Again, it's got broad spectrum, extended spectrum, and also carbapenemases. And all their names are starting with oxa. So if you see some enzyme called oxa, it belongs to class D. If you see an enzyme called KPC, it belongs to class A. Something called AMPC belongs to class C, and NDM, VIM belong to class B. So this is one classification. Then you've got another classification, that is the Bush-Jacobi Medeiros. Just remember the name. I'm not going to go into the detail. For all practical purposes, most of the questions come from Ambler classification, so you don't have to go into the details of Bush-Jacobi Medeiros. So here if you see, this is the classification. It's a little bit more complex, and this categorization of A, B, C and D is also including what are the substrates. I'm not going into the details of that now. That is not important. You don't have to break your head over the second table. Just remember what I told you about class A, B, C and D. Okay. Whenever you see the word carbapenemase, it means that a carbapenem is also inactivated there. Whenever you see a word extended spectrum beta lactamase, it means that the beta lactams, that is penicillins, and first, second, third and fourth generation cephalosporins are also inactivated there. Then suppose you see the name AMC, you should remember that penicillins and rather cefamycins and third generation cephalosporins are also inactivated there. So cefepime is a fourth generation cephalosporin that will work against these AMC producers. Then what else can we discuss from this group? Zinc binding is of course for class B, and all the others has got serine at the active site. Okay. So this we already mentioned, that efflux pump is a mechanism for mainly tetracycline resistance, also for a number of other drugs. It's seen in Pseudomonas, also in E. coli, altered PBP and methylation of ribosomal RNA seen in macrolides, that is erythromycin group. Erythromycin, azithromycin, they are the ones that cause methylation of ribosomal RNA. Okay. So we'll just take a short break and then we'll come back in 5 minutes. Okay, so now welcome back. The next question, a 28-year-old woman presents to the clinic with recurrent sinus infections and history of frequent respiratory tract infections since childhood. She also reports episodes of diarrhea and has been treated for Giardia infection multiple times. Laboratory tests reveal low levels of all immunoglobulin subtypes with a particularly marked reduction in IgA levels. Further evaluation shows normal T cells and B cell counts. Which of the following is most likely the underlying immunodeficiency in this patient? Is it severe combined immunodeficiency, common variable immunodeficiency, selective IgA deficiency, or hyper IgM syndrome? Okay. So she is a 28-year-old woman. Then what all are the classic findings you see here? Recurrent sinus infections, recurrent respiratory infections, diarrhea, giardia. They specifically mention giardia there. Lab tests for the immunoglobulins all are low, but definitely very low is IgA. Normal T and B cell counts, which is the most likely reason, which could be the most likely reason for this. So all these points that I have underlined are give you correct indications as to what the answer is. So we'll have to go through this one by one. Okay. So is it severe combined? Is it common variable? Is it selective IgA deficiency or hyper IgM deficiency? Okay. So let's look at one by one options. If it's severe combined immunodeficiency, in that both B and T cell counts will be very low combined. So both have gone. So definitely it's not severe combined. If it's common variable immunodeficiency, what is the problem in common variable immunodeficiency? Is it only IgA that is low or are the other immunoglobulins also low? The others, all of them are equally low. There's nothing like one is very much low, right? Then in hyper IgM syndrome, what happens? The name itself has it. Hyper IgM. So IgM would be normal or excess, which is not the case here. So in this question, the most probable thing wherein the patient is presenting with sinopulmonary, that is respiratory infections, sinus infections, diarrhea due to giardia, and all the immunoglobulins being low, that's a little tricky, we'll discuss that. But with a marked reduction in IgA levels and normal T and B cell counts, all point to the diagnosis being selective IgA deficiency. Now, if anyone is confused, don't be, because we're going to be looking at this in detail. So first option was SCID, severe combined immunodeficiency. It's the most severe form of primary immunodeficiency in which there is complete failure, that is absolute failure of T and B cell development. So there will be almost no circulating T or B. So any question that says T is normal or B is normal or both are normal, SCID is ruled out. Because in SCID, there is absolute failure of T and B cell development, very low circulating T and B, almost nil. So in this question also, you can rule out SCID. Okay, but what is it actually? In SCID, what happens? So this is what happens in SCID. The thymus does not develop. There is very low circulating level of lymphocytes, very difficult to mount any immune response, and absolutely no activity against any mitogens or antigens. So the core problem is that the thymus is not developing. So lymphoid progenitor cells onwards, they get affected. So none of the cell lines, that B or T cell lines, are coming after that, and it's complete failure of T and B cell development. So here you can see, okay, in SCID, the lymphoid progenitor cell itself is getting affected because the thymus as such is not developing. Then hyper IgM. So in hyper IgM syndrome, point number one is it's X-linked. So here what happens, the isotypic switching of IgM secreting B cells to other cells, that is what is not happening. So you know that when the B cells are producing IgM, they will undergo isotypic switching and start to produce the other immunoglobulins also, that is IgG, IgA, IgD and so on. But here that isotyping switching is not happening. So hyper IgM, the IgM secreting B cells do not switch over into the other classes. So there is normal or excess IgM, but there is absence of other classes. And it's more susceptible to pneumocystis jirovecii infection. So all these points are important. It's X-linked, The switching of IgM secreting B cells, that is what gets affected. So IgM will be normal or excess, but the other classes will be low. And pneumocystis jirovecii infection, it is more prone for. So in this question, this low IgG with, decreased immunoglobulins with particularly low IgA and giardiasis, these are all very key pointers to the diagnosis. And they've also asked which could be the most probable cause. So the most common primary immunodeficiency is isolated IgA deficiency that occurs in 1 in 600 individuals. So here what happens is that the IgA secreting B cells do not become plasma cells. So if IgA is not becoming, secreting B cells are not becoming plasma cells, then mucosal immunity gets affected. And IgA will be very low. But in the question they have said other immunoglobulins are low. But normally other immunoglobulins are normal or even excess. So that is the only differing point from the question wherein they have said all classes are low. All other classes will be normal or even excess, but only IgA will be low. So IgA secreting B cells do not become plasma cells. In hyper IgM, IgM secreting B cells do not undergo isotypic switching. So here the IgA will be very low, whereas in hyper IgM, IgM would be normal or even excess. Okay. And the second most common disorder which can see primary immunodeficiency which is seen is common variable immunodeficiency, wherein the patient will present with a pan-hypogammaglobulinemia. So all that is in common variable, what happens is that B cells do not become plasma cells. Okay. So it's not about IgA or IgM, nothing. B cells do not become plasma cells. So low circulating levels of plasma cells, low IgG, IgM, IgA, recurrent infection. So it's a problem with the B cell function. So the B cell function is what is defective here. Okay. So once again, before I go into the table, SCID means total absence of B and T cell development. Thymus is not developing. Lymphoid progenitor cells are not developing. Nothing is there. A lot of infections, very severe. Then coming to the B cell disorders. The first one is common variable. In common variable immunodeficiency, what happens is that the B cells do not become plasma cells. So when they don't become plasma cells, there will be low plasma cells, low all levels of immunoglobulins, recurrent infection. Then coming to hyper IgM. In hyper IgM, what happens? Isotypic switching of IgM secreting B cells does not happen. It's an X-linked condition. So as a result, what happens is that IgM secreting B cell is not becoming plasma cell. So IgM will be normal or even excess. But the others could be low or even normal. That can happen. And pneumocystis jirovecii infection is commonly seen in this. Then the most common primary immunodeficiency is IgA, selective IgA deficiency, where IgA secreting B cells do not become plasma cells. So IgA alone will be low, others could be normal or even excess. Okay, so now I hope you understand why in this question we came to the answer as IgA secreting B cells. All the pointers are there. Then I also want you to have a look at this table. Okay, that is, if you look at it, what is the type of pathogen that you can see in T cell defect, B cell defect, granulocyte defect and complement defect. Now in T cell defect means that they can have bacterial sepsis due to any type of pathogen. But if you look at the viral markers, the viral infections to which T cells are more commonly prone, the herpes viral infections, that is CMV, EBV, varicella, they are highly prone to that. And fungal infections like Candida and Pneumocystis jirovecii, yes. But parasitic infections normally not seen and they get aggressive disease. Okay, and whenever the T cell is not there, it will be a lot of opportunistic infections. Aggressive opportunistic infections will be seen in T cell defect. So we already said that the viruses belong to herpes virus family and Candida and Pneumocystis jirovecii. Then if you look at the B cell defect, in B cell, it's usually could be because the normal bacterial pathogens you get to see would be staph, strep, pneumonia, that's Streptococcus pneumoniae and Haemophilus influenza. The viruses, usually it's enterovirus encephalitis, and one stark point is giardiasis. So here you can see giardiasis. So you have to think from the question itself, it could be a B cell defect. That is a pointer that I said you should remember. And recurrent sinopulmonary infections, sepsis, and meningitis can also be seen. So, staph, Streptococcus pneumoniae, and Haemophilus influenza, enterovirus encephalitis, and GRDS is seen in B. Then when you look at a granulocyte defect, it could again be staph, pseudomonas and nocardia. And of course, candida and aspergillus infections are again common. So the fungal thing is actually not seen with B. But candida and pneumocystis jirovecii is seen in T. Candida and aspergillus is seen with granulocyte. And for complement, it could be any type of pyogenic infections, and usually Neisseria is also one that is associated with complement defects. So this table also, if you can get it into your head, it will help you to identify based on the clinical history what could probably be the reason. So here also you know that cyanopulmonary infection, GRDS is all that was given in the question. So you can quickly zero in onto a B cell defect. Okay. Then coming to the next question. A 30-year-old woman presented to the clinic with a 2-week history of fever, malaise and sore throat. On examination, she has cervical lymphadenopathy and splenomegaly. The physician suspects infectious mononucleosis and orders a rapid heterophile antibody test, which is known as the monospot test, which comes back positive. Which of the following is most likely causative agent that is being detected by the heterophile antibodies in this patient? Is it cytomegalovirus, Epstein-Barr virus, Toxoplasma gondii, or Streptococcus pyogenes? So, this is a relatively straightforward question. The patient has a 2-week history of fever, malaise, sore throat with lymphadenopathy, splenomegaly. Clinician being smart, he thinks of IMN. He orders a monospot test, which is positive. So it is IMN, infectious mononucleosis. So the question here is whether you know what is the causative agent of IMN. Is it cytomegalo, EBV, Toxoplasma gondii, or Streptococcus pyogenes? So here, infectious mononucleosis, monospot positive, it is Epstein-Barr virus. Okay. Now, in this question, let us discuss what is heterophile. So, the heterophile antibody test, that is the monospot test, is used to diagnose infectious mononucleosis caused by EBV. What is meant by heterophile antibody test? What are heterophile antigens? These are antigens that are present in two entirely different species which share epitopes with each other. So, these antigens are seen in two different species, but they share epitopes. Because of this, antibody against one will cross react with the other. Isn't that very clear now? Okay, that will cross react. So there are 3 named heterophile agglutination reactions that you must always remember. One is the Weil-Felix. Weil-Felix is used to diagnose rickettsial infections. It is a heterophile agglutination test where in order to diagnose rickettsia, you are using the antigens of non-motile protease mirabilis OX19, OX2 and OXK. So these antibodies will be cross-reacting with this, and from that you understand that the infection is due to rickettsia, Weil-Felix. Okay, that is one. Second one is in infectious mononucleosis, the Paul-Bunnell test. Okay, the other one was monospot. That's also a rapid heterophile. But Paul-Bunnell test mainly uses sheep RBC antigens. So sheep RBC antigens are used in to detect EBV. That is in Paul-Bunnell. Then comes the cold agglutination test and the Streptococcus MG test. That is mainly used to detect Mycoplasma pneumonia. So there you are using human O group RBCs and Streptococcus MG antigen. So that is how you are detecting the Mycoplasma pneumonia. So heterophile agglutination means that the antigens are present in 2 entirely different species and their epitopes are shared. So antibody against one will cross-react with the antibody against another, will cross-react with the other antigen. 3 main reactions. One is Paul-Bunnell, that is to diagnose rickettsia. That's using protease strains OX19, 2 and K. Then sheep RBC antigens are mainly used for diagnosing infectious mononucleosis, and the test used is Paul-Bunnell test. Causative organism is EBV. Then Streptococcus MG test and cold agglutination test for the diagnosis of primary atypical pneumonia, which is caused by Mycoplasma pneumoniae, using human O group RBCs and Streptococcus MG antigens. Okay, so now I hope that you will never confuse this. Now coming back to the other option, CMV can present like this, but definitely you will not get a monospot test positive and it does not produce heterophile antibodies. Toxoplasma also can produce this, but again no heterophile antibodies and no monospot test positivity. Streptococcus and pyogenes mainly cause streptococcal pharyngitis or some other condition like that. That is definitely not associated with a positive monospot, and it's got totally different set of tests also. You can do the ASO titer, okay, not a monospot test for that. Then a 28-year-old pregnant woman comes for her first prenatal visit. She mentions that she had chickenpox as a child and is concerned about possible exposure to varicella during her pregnancy. The physician reassures her that since she has had chickenpox before, she likely has immunity. A blood test is ordered to confirm her immune status, and the results show the presence of IgG antibodies against varicella zoster. What does the presence of IgG antibodies against varicella zoster virus indicate in this patient? Recent acute infection with varicella zoster, immunity due to past infection or immunization, active viral replication and contagiousness, no immunity and susceptibility to varicella infection. So she's pregnant, she's had chickenpox in her childhood, but now she's concerned whether she's again putting herself and her baby at risk, whether she'll again get varicella. Okay. So the clinician orders a blood test in which IgG antibodies against varicella zoster is positive. Now, what does the presence of IgG antibodies indicate? Does it indicate recent acute infection? No, they have not mentioned anything about IgM. IgG is something that can be seen long term. It usually does not indicate recent. In that case, it would have been IgM positive, so that is not the answer. Immunity due to past infection or vaccination, that could definitely be a possibility here, because IgG antibodies usually indicate either previous infection or immunization. Active viral replication and contagiousness, to come to that conclusion, you should be able to demonstrate the viral particles or the viral antigen somehow. You cannot say that by just doing an IgG test, and no immunity and susceptibility. If the immunity was not there at all and she was in fact susceptible, her IgG would have been negative, but here it is positive. So it does not mean no immunity. No, it means immunity and not susceptible because of a past infection or an immunization. So the presence of IgG antibodies indicate immunity to the virus due to the previous infection. So she is likely to be immune. She doesn't have to be concerned. She will not transmit the disease again during her pregnancy. Okay. Then these options we've already discussed. It should be IgM to call it acute. And for viral replication, you have to demonstrate the virus itself. And IgG is already there. So that does not mean that she is non-immune. It means that she is immune. Okay. Then, a 45-year-old man presents to the clinic with symptoms of fever, fatigue, and joint pain. His physician suspects an autoimmune condition and orders several serological tests. The laboratory performs an enzyme linked immunosorbent assay to detect the presence of specific autoantibodies in the patient's blood. The following image shows the results of the ELISA test. You can see that some of the wells are colorless, some of the wells are blue. Based on the image, which of the following best explains the principle of the antigen-antibody reaction observed in this ELISA test? So this is one of those classical questions where it begins somewhere and travels across. So the patient has some symptoms for which the clinician wants to look for an autoimmune test. He puts the patient through a number of serological tests, one of them being ELISA. Okay, and the results have been shown of the patient's ELISA, and there are different colored wells. You can see some of the wells are blue, some of the wells are not. And what is the principle of ELISA? That is the question, which is best explains the principle of the antigen-antibody reaction. Is it option A, the color change indicates the binding of an antibody to a specific antigen, with the intensity of color being proportional to the amount of antibody present. The color change indicates the lysis of red blood cells proportional to the amount of antigen present. The lack of color change in a well indicates a positive result due to the absence of antigen antibody binding, or the color change occurs due to the precipitation of antigen antibody complexes, which is directly proportional to the concentration of the antigen. Okay, so which of these is the principle of ELISA? So for in ELISA, it's an enzyme-linked immunosorbent assay. The color change is directly proportional to the amount of antigen or antibody, whatever it is that you're detecting in the serum. And it is brought about because of the binding of the antibody to the antigen present. So the binding is what is responsible. It does not indicate lysis of red blood cells, and the lack of color actually indicates a negative result, not a positive result at all. So there is no color, it is a negative result. And it is not due to the precipitation, it is due to the binding. Okay, it is not due to the precipitation, right? So let's discuss a little bit about the ELISA so that you get the concept more clear. So ELISA is basically a system that is enzyme-linked immunosorbent assay that is used to detect antigen or antibody, and it's got an enzyme substrate chromogen system. So in ELISA, there is the enzyme substrate chromogen system, and in principle what happens is that the enzyme is linked either to the antigen or the antibody, and the immunosorbent is also attached specifically to the antigen or the antibody. So enzyme labeled component is there, and the immunosorbent is also attached to the antigen or the antibody. Then the substrate chromogen mixture is added in the final step. So the substrate goes and binds to the enzyme, that is enzyme substrate complex binds, and the chromogen gets activated and the color is produced. This is detected by spectrophotometry, and the intensity of color is directly proportional to the amount of antigen or antibody in the sample. So depending upon how much of antigen or antibody is there, it will go and bind and the color will be more. So it can be used to detect antigen or antibody. There is an enzyme substrate chromogen system in there. There is an enzyme labeled antigen or antibody. There is what do you call that, the immunosorbent. Immunosorbent comes and attaches specifically to the antigen or antibody. The substrate chromogen system is then added, and substrate goes and binds to the enzyme, chromogen gets activated, color is produced, and the amount of color produced is directly proportional to how much antigen or antibody is there in the system. So this is an ELISA reader, and this is a washer. These are the images of that. And there are different types of ELISA. There is direct ELISA. Direct means always antigen detection. And there's an enzyme labeled primary antibody for the detection of antigen. Indirect ELISA means it is antibody detection. There is enzyme labeled secondary or anti-antibody that is used for antibody detection. Sandwich ELISA means something is getting sandwiched. That is mainly used for antigen detection. The antigen gets sandwiched between the capture and the detector antibody. Okay. So in this here you can see there is a capture antibody and there is a detector antibody, and this is the antigen that is actually getting sandwiched. So in sandwich ELISA, the antigen gets sandwiched or the antibody can get sandwiched. And a special type of a sandwich ELISA with antibody getting sandwiched is what is known as IgM antibody capture ELISA, that is MAC ELISA, IgM antibody capture. That is what is used for the diagnosis of leptospirosis, Japanese encephalitis, scrub typhus, dengue, for all this. Okay. So here what happens is the primary IgM antibody is captured by a recombinant antigen and a secondary, that is an enzyme labeled secondary antibody. So here you can see this is a capture ELISA. You've got the anti-human IgM here, and this is the IgM antibody which you want to find out. So anti-human antibody, then the IgM antibody comes and binds to that. You've got a recombinant antigen and an enzyme labeled secondary antibody, and that is the one that will produce the color change, and this is what is commonly used for all the above tests. All the tests which I mentioned before, including leptospirosis and dengue. Then there is something called as a competitive ELISA. Competitive ELISA can actually be used for either antigen or antibody detection. So the antigen in the test serum will have to compete with another antigen for the antibody. So that is how the process actually happens. So you're incubating the antibody with the antigen that has to be measured. So, so you've got, like here, if you can see in this image, there is an antigen coated well, okay, and the antigen has been already incubated with the antibody. Now, if the antibody goes and binds to that antigen, then it is no longer free to come and bind to the antigen which is present in the well, okay. And once it is, all the process has been done and you've added the enzyme conjugated secondary antibody, it can come and bind only if it is coated the antigen that is present in the well. So in effect, suppose a test serum antigen binds to the primary antibody, then the secondary antibody cannot bind, so there will be no color. So the amount of color that is produced is inversely proportional to how much of antigen is there in the test serum. Okay, now I hope you got this very well. This is competitive ELISA. Can be used for antigen detection or antibody detection. So there, suppose it is being used for an antibody detection, then suppose it's being used for an antigen detection, then the antigen is first incubated with the primary antibody. If they bind, then the primary antibody cannot go and bind to the antigen which is there in the well. Then subsequent reactions including color will be very less. So the amount of color produced is inversely proportional to how much of antigen is there in the test. Okay. So that is the one there. Then you've got ELISpot. So ELISpot is again a type of ELISA that is used to detect cytokines and plasma cells, and that is what is used in IGRA. So none of the other options that are given have got anything to do with ELISA. The amount of color produced is dependent upon the binding, okay, and the amount of antigen or antibody in the test sample. And the basic principle is this binding that is responsible for the development of color. What are the different types of ELISAs which we discussed? You've got direct, indirect, antigen capture, IgM and antibody capture, that is the MAC ELISA, competitive ELISA, then you've got ELISpot. Okay. Then, a 32-year-old man presents to the clinic with complaints of persistent fatigue and recurrent respiratory infections over the past 6 months. Physical examination reveals generalized lymphadenopathy. Laboratory investigation shows a marked decrease in CD4 T cell count. Flow cytometry is performed and the results indicate a significant reduction in the population of CD4 T cells, while other lymphocyte populations, including CD8 plus T cells and B cells, are within normal limits. Which of the following conditions is most likely responsible for the patient's clinical condition? Is it HIV, SCID, chronic lymphocytic leukemia, or Hodgkin's lymphoma? So, this is a patient with some generalized symptoms and fatigue, generalized lymphadenopathy, okay? And from here onwards comes the interesting part. Its marked decrease in CD4 T cell, which is again substantiated in the flow cytometry, but the CD8 T cells and B cells are all within normal limits. So the most common reason why CD4 T cells should selectively be less, that is HIV. Okay, but can we really choose that as an option? Is there something else? So in SCID, again, we said the other cell populations are normal, like CD8 T cells and B cells. So SCID is definitely out. What about chronic lymphocytic leukemia and Hodgkin's lymphoma? We'll see that in the discussion. So chronic lymphocytic leukemia means the B cells are the ones that should be increasing, but here it is not there. So that is again the reason why it's not CLL. And Hodgkin's lymphoma, there will not be such a specific reduction in CD4 plus T cells. Okay, it can present with lymphadenopathy and immunosuppression and all that, but such a severe and specific reduction in CD4 plus T cells alone will not be seen in Hodgkin's. So that is the reason why the answer is HIV. So here in this question, it's neither CLL because B should have increased. It's not Hodgkin's because of how specific the reduction in CD4 plus T cells is. Okay. A 25-year-old woman presents to the emergency department with sudden onset of shortness of breath, wheezing, and generalized hives after eating at a seafood restaurant. She reports a history of mild allergies but has never experienced a reaction like this severe. On examination, she was in respiratory distress with a rapid pulse and low BP. The clinical team suspects an anaphylactic reaction. Which one of the following immune mechanisms is primarily responsible for the patient's symptoms? Is it IgE mediated release of histamine from mast cells and basophils? Complement activation leading to cell lysis? Immune complex deposition in tissues? Or cytotoxic T cell mediated destruction of target cells? So this is a lady who is coming to the ED with features of shortness of breath, wheezing, generalized hives. She just had food from a seafood restaurant. She does give histories of allergies, but she has never experienced a reaction that is this severe. And when you see her, she is in respiratory distress, her pulse is rapid, her BP is low, and the team is suspecting an anaphylactic reaction. So one thing is for certain, she does have an anaphylactic reaction because all her symptoms and all the examination findings are pointing towards that. Which of the following mechanisms of hypersensitivity is actually responsible for causing this type of a reaction? Is it a type 1, type 2, type 3 or type 4 hypersensitivity that we see here? So anaphylactic reaction is a type 1 hypersensitivity. So cytotoxic T cell mediated destruction of target cells is a mechanism of type 4 hypersensitivity or delayed hypersensitivity, which is definitely ruled out in this case. Immune complex deposition in tissues is a type of a type 3, that is an immune complex mediated, so that is again ruled out. Complement mediated, that is complement activation leading to cell lysis, is a type 2 hypersensitivity reaction. That is also not the one that is responsible for anaphylactic reaction. Instead, for anaphylaxis, what is responsible is the IgE mediated release of histamines from mast cells and basophils. So, it is classical explanation of a type 1 hypersensitivity, which is what is responsible for anaphylaxis. So a type 1 hypersensitivity has got numerous allergens. It could be food products, it could be plant pollen, vaccines, drugs, insect products. So many different things can be responsible for as an allergen for a type 1 hypersensitivity reaction. And it is mediated by the immunoglobulin IgE, which is homocytotropic and which mediated the Prosnitz-Kussner reaction. Which are the cells of the hypersensitivity that's type 1 hypersensitivity? It is a mast cell and the basophils. And there are numerous mediators, both primary and secondary. Primary mediators are preformed mediators, whereas secondary mediators have to be produced. So which are the primary mediators? Histamine, heparin, serotonin, very important. Eosinophil and neutrophil chemotactic factors and hydrolases, proteases, these are the primary mediators. Secondary mediators, prostaglandins, leukotrienes, it's LTC4, D4E4, which is known as SRSA, and bradykinins, okay, together with PAF. So these are the secondary mediators. So prostaglandins, leukotrienes, bradykinins, and PAF, they are the secondary mediators. So primary is histamine, heparin, and serotonin, and secondary are prostaglandins, leukotrienes, PAF, and bradykinin. Okay. So what actually happens in type 1 hypersensitivity? So the allergens in type 1 hypersensitivity is taken over by the antigen presenting cells. It is processed and presented to the T helper cells, and B cells are also a type of antigen presenting cell, so they'll be presenting it as well to the T helper cells. And these T helper cells will further differentiate through the Th2 lineage and subsequently cause the release of interleukin 4. Now, this interleukin 4 is responsible for the differentiation of B cells into memory cells and plasma cells. So, memory and plasma cells will be produced, and this plasma cells will be producing a lot of allergen specific IgE. So a lot of allergen-specific IgE is produced by these plasma cells, which goes and binds to the receptor on the surface of mast cells and basophils. So that Fc portion has got an Fc receptor on the surface of mast cells and basophils, and this will go and bind there on the surface, and it forms what is known as a sensitized mast cell. So once the Fc receptor has got the Fc portion of the IgE bound, such a mast cell is known as a sensitized mast cell. Okay. Subsequent exposure to the allergen will cause the cross-linking and degranulation of the mast cell. So when it comes a second time, it will cause the cross-linking of the IgE, resulting in degranulation of mast cells and basophils and production of a lot of vasoactive amines. These vasoactive amines are responsible for the effects of the IgE mediated hypersensitivity. So what are the effects that you get to see? Smooth muscle contraction, increased vascular permeability and vasodilatation, then increased mucosal secretion, itching because of the sensory nerve endings getting stimulated, platelet aggregation. Okay, so all these effects are because of the release of vasoactive amines. So you've got the interleukin 4 stimulating the B cells to form memory and plasma cells producing allergen specific IgE, going and binding onto the surface of the mast cells to form sensitized mast cells. This happens on first exposure. On second exposure, this IgE will cross-link, cause degranulation of the mast cells. A lot of vasoactive amines will be released, and these are the ones that are mediating the other effects, that is increased vascular permeability, vasodilatation, bronchoconstriction, mucosal secretion, okay, platelet aggregation, and so on. Then there are different types of anaphylaxis, systemic anaphylaxis. There are two types of anaphylaxis. One is systemic and the other one is localized. So systemic anaphylaxis can be a shock-like state, or it can be cutaneous anaphylaxis, which is the wheel and flare reaction, which is the basis of the Cassoni's test. Then anaphylaxis in vitro, that's Schultz-Dale and Theobald-Smith. All these names you should remember, they are all manifestations of systemic anaphylaxis, whereas localized anaphylaxis is known as atopy, allergic rhinitis or hay fever is an example, then asthma or angioedema, then food allergies, that is atopic urticaria or hives, then skin manifestations like atopic dermatitis. All these are examples of localized anaphylaxis. Okay. Then the other ones are type 2, type 3, type 4. We already discussed that. So there is systemic and localized. Systemic can be shock-like state, then wheel and flare reaction, Theobald-Smith and Schultz-Dale phenomenon. And localized can be either hay fever, angioedema, or it can be urticaria or hives because of having some kind of food, or it can be atopic dermatitis as well. Then, next question. A 4-year-old boy is brought to the pediatric clinic by his parents due to a history of recurrent bacterial infections, including pneumonia, otitis media, and sinusitis. The infections have been severe and require multiple courses of antibiotics. Laboratory tests reveal very low levels of all immunoglobulin classes, that's IgG, A, and M, and flow cytometry shows a significant reduction in mature B cells. T cell numbers are within normal limits. Which of the following is most likely to be the cause of this condition? Is it severe combined, common variable, X-linked agammaglobulinemia, or Bruton's agammaglobulinemia, or DeGeorge's syndrome? So again, a similar question to the one which we previously discussed. He's been brought by his parents. He has recurrent bacterial infections, pneumonia, otitis media, sinusitis. Okay, and the clinician checks his immunoglobulin levels, and low levels of all immunoglobulin classes, IgG, A, and M. And flow cytometry shows a significant reduction in mature B cells. T cell numbers are normal. These are the classical clues. So is it severe combined immunodeficiency? You know that both T and B cells should be absent or very low. So that is ruled out. Is it common variable immunodeficiency? We said common variable immunodeficiency means that the B cells are not becoming plasma cells. So the plasma cells numbers will be low. But here it is the mature B cell number that is low. So it's not common variable immunodeficiency either. Is it X-linked A-gamma globulinemia or Bruton's A-gamma globulinemia, or is it D. George's syndrome? So if you know the difference between these two, you can arrive at the answer. So it is X-linked A-gamma globulinemia because pre-B cells are not becoming B cells. So that is the reason why the B cell numbers are defective. Whereas D. George's syndrome is a congenital thymic aplasia. That is totally different, wherein hematopoietic stem cells are not becoming T cells. Here we already know the T cell numbers are normal, so that is definitely not the reason. Okay. Even otherwise, the immunoglobulin levels are low. That is all the B cell defects only which normally produces that kind of condition. So here it is X-linked A-gamma globulinemia. So SCID we have discussed. I won't be saying that again. You've seen this image also from the lymphoid progenitor downwards. Everything is gone in SCID. So nothing will be there in SCID. Okay. Then D. George's syndrome, it's congenital thymic aplasia. It's otherwise known as third or fourth pharyngeal pouch syndrome, wherein there will be hypothyroidism and hypocalcemic tetany. It is because of the deletion of chromosome 22. And here, like I said, hematopoietic stem cells do not become T lymphocytes. So there's an impaired T cell development. That is D. George's syndrome. Okay. Then, what are the primary B cell deficiencies? It's common variable immunodeficiency, X-linked A-gamma globulinemia, and selective IgA deficiency. Then hyper IgM deficiency. All these are, the primary B cell immunodeficiencies. So, the deficiencies wherein the mature B cells do not become plasma cells. Now try and remember the previous discussion. Okay, here you've got mature B cells which will be normal. Plasma cells will be reduced. So in common variable immunodeficiency, B cells do not become plasma cells. In X-linked hyper IgM, the IgM secreting B cells do not undergo isotypic switching to become the rest of them. So again, that is a problem between the B cell and the plasma cell. In selective immunoglobulin deficiency like IgA deficiency, the IgA secreting B cells do not become plasma cells. So in all these conditions, the B cell numbers will be normal. Now, Bruton's A-gamma globulinemia. So in Bruton's A-gamma globulinemia, what happens is that the pre-B cell does not become B cell. So B cell to plasma cell. So let me write it here. Pre-B cell, B cell, plasma cell. Okay. So in Bruton's A-gamma globulinemia, the pre-B cells have got a problem with the BTK gene, that is Bruton's tyrosine kinase gene. It's an X-linked problem. So they do not become the B cells. So as a result of that, what happens? B cell maturation is not taking place. There are no peripheral B cells or plasma cells. Okay, and low levels of IgG and the other immunoglobulins are totally absent. There will be increased susceptibility to staph, pneumococci, pyogenes, Neisseria meningitidis, Haemophilus influenzae, and Pneumocystis jirovecii. We learned this in that table. Okay, so pre-B cells do not become the mature B cells. That is the problem here. So, if you look at it, pre-B cells do not become mature B cells in Bruton's A-gamma globulinemia. Okay, and as a result of that, the B cells will be low and the plasma cells also will be low. Okay, now B cell to plasma cell, the defect like we mentioned is common variable immunodeficiency, hyper IgM, IgA deficiency. Here the B cell will be normal, but the plasma cells will be low. Now I hope that you've understood this very clearly. Okay. Now over to the next question. Let me just take a sip of water. A 30-year-old man presents to the emergency department with sudden onset of severe nausea, vomiting and abdominal cramps. He reported that the symptoms started about 4 hours after eating potato salad at a picnic. Looks like potato salad is a big problem, isn't it? Several others who ate the same food also fell ill. The patient did not have a fever and his vitals are stable. His past medical history is significant for a recent skin infection treated with antibiotics. Given the rapid onset of symptoms and the context, food poisoning caused by Staphylococcus aureus is suspected. Which of the following is the most likely mechanism of illness in this patient? Ingestion of preformed enterotoxin produced by Staph aureus, invasion of the gastrointestinal mucosa by Staphylococcus aureus, production of a heat labile toxin that causes GI symptoms, endotoxin release from MRSA. Okay, so here there is a person who's gone on a picnic, eaten some salad, potato salad, and who's taken ill. He's having symptoms, but he's not that sick. Okay, his vitals and everything is stable, and he does give a history of a recent skin infection, some kind of a skin infection. So again, it could be a staph skin infection that's treated with antibiotics. Now, given the rapid onset, his symptoms were so quick, like he ate it and about 4 hours later, it started, his problem started. So given the rapid onset, it's a Staphylococcus aureus, food poisoning that is suspected. And the only question that this boils down to is what is the mechanism of action of Staph aureus food poisoning? Okay, is it endotoxin release from MRSA? Absolutely not. It's got nothing to do with the Staph aureus food poisoning. Production of a heat labile toxin, stable toxin, all that is that causes GI symptoms is usually seen with E. coli, not this. There is no invasiveness, invasion of the mucosa, that is a feature of shigellosis. We discussed this, correct? It's got nothing to do with Staph aureus. But yes, the short and rapid, turn of events that is classically seen with Staph aureus is because of ingestion of a preformed toxin, and that is the right answer. So I'm just using this question to quickly revise what are the toxins produced by staph. There is membrane active toxins, then epidermolytic or exfoliative toxins, enterotoxins, and toxic shock syndrome toxins. Okay. So among the membrane active toxins, you've got hemolysins and leukocidins. Leukocidins are otherwise known as panton-valentine toxins. Hemolysins are alpha, beta, gamma, and delta. And these three, that is epidermolytic or exfoliative toxins, enterotoxins, and TSST toxins, these together they are called as super. These are super antigens. Okay. Then, enterotoxin of Staphylococcus aureus is a superantigen. It's a preformed toxin that makes it very rapidly acting. That is responsible for the short incubation period of 1 to 6 hours. And the primary targets are the vagus nerve and the vomiting center of the brain. They are the primary targets. Nausea, vomiting, abdominal cramps is usually seen. Diarrhea could be present, but predominantly it's a vomiting predominant type of a symptomatology that it presents with. There will be no fever. It's self-limiting. Within 24 to 48 hours itself, it will be gone. And ham, poultry, mayo, milk and milk products, these are normally the ones that are implicated. And ELISA, latex agglutination, or a PCR to demonstrate the gene that can be done. Supported treatment is only need to be given, like we said, within 24 to 48 hours it will settle. So it's a preformed that explains the rapidity of action. Within 1 to 6 hours the symptoms will start, and it's mainly a vomiting predominant, although there could be diarrhea, but the person doesn't become so severely ill. ELISA, latex agglutination, and PCR to detect the toxin can all be used for diagnosis. And it stops within 24 to 48 hours, and only supportive treatment is needed. Now, in this question, I have again brought back this table, this famous table, which you probably would have seen in the textbooks or in some other discussions as well. It's a very useful one. You have to categorize food poisoning into 3 broad categories based upon the time, that is the incubation period it takes. Okay, is it 1 to 6 hours? Is it 8 to 16 hours or more than 16 hours? So 1 to 6 hours, there's only Staph aureus and Bacillus cereus that are involved. And it is vomiting predominant. Okay, although the diarrhea is mentioned, it's mainly vomiting and abdominal cramps that are predominant. It's not diarrhea as much. We already said that Staph aureus is due to dairy products, mayo, poultry, ham, and all those things. Whereas Bacillus cereus, it's mainly a fried rice induced. Then 8 to 16 hours could be Bacillus cereus diarrheal type, or it could be Clostridium perfringens. So here it's more of an abdominal cramps and diarrhea. That is a symptom that is seen. And Clostridium perfringens could be beef or legumes or whatever, whereas cereus is because of meat and vegetables. They are the predominant ones. Then more than 16 hours, you've got so many: Vibrio cholerae, enterotoxigenic E. coli, enterohemorrhagic E. coli. Then you've got non-typhoidal salmonella, Vibrio parahemolyticus, Campylobacter, norovirus. So many organisms here, Shigella, all of them can cause this sort of food poisoning. So if you look at Vibrio cholerae and enterotoxigenic E. coli, they normally produce watery diarrhea. Vibrio cholerae is usually associated with water, but shellfish is also implicated in Vibrio cholerae food poisoning. Enterotoxinic E. coli is classical of traveler's diarrhea, salads, cheese, meat, water. Water is a very important agent for both of these actually, for VC as well as enterotoxigenic. Enterohemorrhagic E. coli, we already said it could be, ground beef or it could be ground beef or some kind of vegetables, salads, raw vegetables in the salads, apple juice, all these could be responsible, and it produces a bloody diarrhea, enterohemorrhagic E. coli. And non-typhoidal salmonella usually produces inflammatory diarrhea. Shigella usually causes dysentery. And Shigella is again associated with potato and egg salad. Then non-typhoidal salmonella is again associated with juice, raw fruits, milk. So these are some of the agents that you need to remember, which are classically seen associated with diarrheas of different forms. Then Vibrio parahemolyticus is also associated with shellfish, particularly oysters. So sometimes you can confuse it with Vibrio cholerae. But the main thing is that parahemolyticus presents as dysentery, whereas cholerae presents as watery diarrhea. So that's one main difference there. Then Campylobacter jejuni causes inflammatory diarrhea. Clostridium botulinum, we all know it's more of the dysphagia, diplopia, those kind of symptoms due to canned foods or improperly stored honey. All that could be implicated. Listeria monocytogenes is also an important cause of diarrhea. Basically, it presents as fever and myalgia in pregnant women. So besides this, there are also some other further down there, but I'm not going into that. I think up until here, if you know, you are fairly secure in expecting to get an answer right. So when you study this also, like when you split it into 1 to 6 hours, 8 to 16 hours, and more than 16 hours. And in more than 16 hours, Vibrio cholerae and enterotoxinic E. coli are quite similar. Then enterohemorrhagic E. coli, that will produce bloody diarrhea. Inflammatory diarrhea is seen in non-typhoidal salmonella. Shigella and Vibrio parahemolyticus normally presents as dysentery. Okay, and then there are other organisms also like Campylobacter, Clostridium, Listeria, which is slightly different, offbeat in their symptomatology. So like this, if you categorize, you can study. This is a little tough table, but if you just read it on a regular basis, you will be able to get the hang of it. Okay. So invasiveness is a mechanism of Shigellosis and enteroinvasive E. coli. Labile toxin is produced by E. coli also, that is ETEC, Clostridium perfringens also, not by Staphylococcus aureus. Okay, endotoxin production is usually a problem that's seen with gram negative and Staph aureus is gram positive. So because of this itself, we can rule out the options. Then a 19-year-old college student presents to the emergency department with a sudden onset of high fever, severe headache, neck stiffness, and a petechial rash. He was previously healthy but became acutely ill within the past 24 hours. On physical examination, he has a positive Brudzinski sign and is visibly uncomfortable. A lumbar puncture is performed and a CSF analysis shows an elevated WBC count with a neutrophil predominance, low glucose and elevated protein, and a CSF gram stain is seen below. Based on the clinical presentation and the findings of the gram stain, which of the following antibiotics is most appropriate for initial treatment for this patient? Is it vancomycin, ceftriaxone, ciprofloxacin, or amoxicillin? So this is a college student who is coming to the emergency department. Okay. High fever, headache, neck stiffness, and petechial rash. Okay, the rash is a very important pointer. But fever, headache, neck stiffness, normally findings of meningitis. It just took him 24 hours to become like this, and he's got a positive Brudzinski sign. He's uncomfortable. You do a CSF lumbar puncture, and it's typical of a bacterial meningitis because the WBCs are elevated. There is a neutrophil predominance, sugar is low and protein is elevated. So it's bacterial. And the gram stain shows, what does it show? Plenty of polymorphonuclear neutrophils and gram negative diplococci. I don't know how clearly you can make out. There are gram negative diplococci, and these gram negative diplococci are seen, that they're all over there extracellularly as well as intracellularly also. You can make out these gram negative diplococci. So they are seen both intra and extracellularly. So which is the organism which forms gram-negative diplococci and can cause meningitis? There's only one diagnosis, that is Neisseria meningitidis. And what is the drug of choice for Neisseria? Is it vancomycin, ceftriaxone, ciprofloxacin or ampicillin? So, or amoxicillin. It's not amoxicillin, it's got no role. Ciprofloxacin also, it cannot be given for meningitis. Ceftriaxone, third generation cephalosporin, is the drug of choice for Neisseria meningitidis. So the right answer is ceftriaxone. It's not vancomycin either, it is ceftriaxone. So clinical presentation, like we said, fever, headache, neck stiffness and that petechial rash, okay, that is highly suggestive of actually meningitis due to Neisseria. That's a typical rash and it's a bacterial meningitis. Then you saw gram-negative diplococci, which are both intra and extracellularly seen. And some of the other features of this diplococci is it is capsulated, it ferments glucose and maltose, and it's lens or half moon shaped. Okay, that is, these are some of the other features of Neisseria meningitis. So, lens or half moon shaped gram-negative diplococci, which is seen intracellularly and extracellularly, and it ferments glucose and maltose. Why I'm saying this is because the other component, that is Neisseria gonorrhea, is non-capsulated. It is kidney shaped. It's predominantly intracellularly seen, okay, not so much extracellular. And it ferments glucose and maltose. So these are the major differences between like Neisseria gonorrhea and Neisseria meningitidis. Then coming to the clinical manifestations, you've got rashes. Okay, these rashes can be petechial or purpuric rashes, then septicemia, then Waterhouse-Friderichsen syndrome, that is actually characterized by severe purpura fulminans. It's got severe purpura, then bilateral adrenal hemorrhages and disseminated intravascular coagulation. And of course, there will be multi-organ failure as well. Then for pyogenic meningitis, the CSF culture as well as the CSF antigen detection is what normally helps in confirming the diagnosis, and it's more commonly seen in children. Then chronic meningococcemia, that will be presenting as a fever, arthritis and rash. Post-meningococcal reactive disease, again with polyserositis and arthritis. Okay, so these are the various manifestations. So if you look at the clinical manifestations, these are all the clinical manifestations. You can have rashes, septicemia, Waterhouse-Friderichsen syndrome, pyogenic meningitis, chronic meningococcemia, post-meningococcal reactive disease. Okay, in that Waterhouse-Friderichsen is purpura fulminans, DIC and bilateral adrenal hemorrhages and multi-organ failure. Then comes the post-meningococcal reactive disease that we already said. Then coming to the treatment, the drug of choice is ceftriaxone or cefotaxime, that is third generation cephalosporins, to be given for 7 days. And among the other options, like of course ceftriaxone, it's highly attains very good levels in the CSF, so that is one reason. And vancomycin can actually be given if it's an area where you expect more of Streptococcus pneumoniae, because pneumococci, they sometimes do show penicillin resistance, so it doesn't make much sense to be giving them only ceftriaxone. So in such areas where you have high rates of penicillin resistance, there vanco plus ceftri, that can be tried for areas with high prevalence of penicillin resistant Streptococcus pneumoniae. Then ciprofloxacin is usually given as a chemoprophylaxis for household contacts of patients with meningococcal disease, and amoxicillin has got no role. Okay, it's typically not used for treating, so that does not have much of a role. So I'll just take a 2-minute break and then we can continue. So welcome back. Now moving to the next question. A 7-year-old child presents to the pediatric clinic with a sore throat, low-grade fever, and difficulty in swallowing. On examination, there is a thick grayish pseudomembrane covering the tonsil and pharynx. The child's immunization history is incomplete and the physician suspects diphtheria caused by Corynebacterium diphtheriae. A throat swab is collected for lab analysis to confirm the diagnosis. Which of the following tests is most appropriate to confirm the diagnosis of diphtheria caused by Corynebacterium diphtheriae? Is it gram stain showing gram-positive bacilli, Ilex test for toxin production, blood culture on McConkey agar, or PCR for the tox gene? So in these questions, the diagnosis is already given. So the 7-year-old child with all these symptoms, sore throat, fever, showing a pseudomembrane that is covering the tonsils and the pharynx. The immunization history is incomplete. They're suspecting Corynebacterium diphtheriae and they're sending it to the lab. Okay, a throat swab is sent to confirm the diagnosis. Now, which of the following tests is most appropriate to confirm the diagnosis of diphtheria? That is the question. So is it gram stain? Is it Ilex test for toxin production, blood culture, or PCR? So here there are two answers which are very closely related and many of you might confuse between either of these. But the question being most appropriate is that is the word that actually points to the answer. Anyway, it's not gram stain because just by seeing gram-positive bacilli on a throat swab, you cannot say that it is diphtheria. Non-toxigenic strains can also have that same arrangement, that is a Chinese letter pattern arrangement, so it's not gram stain. And blood culture on McConkey agar does not deal, give you anything specific to suggest it's a diphtheria. Diphtheria is a toxemia and not a bacteremia, so you don't expect to get it on blood culture either. So that is a totally wrong answer. But both these answers, that is Ilex test for toxin production and PCR for tox gene, both of them do demonstrate toxigenicity. But the best test, the one that is done in reference labs, that is the most appropriate if you may ask, that is Ilex gel precipitation test for toxin production. So that is the reason why that is the correct answer. Although, PCR for tox gene comes very close. Okay. So diphtheria is caused by a toxigenic strains, okay, that has to produce diphtheria toxin. If you do a gram staining, you can just see the Chinese letter pattern, palisade arrangements, that's it. You will not be able to make out whether it is toxigenic or not. So that is not the right option, okay. Then Ilex, okay, now let's speak a little bit about Ilex gel precipitation test. It's the gold standard confirmatory test. It's done only in select labs. So in an agar medium, there is a strip that is soaked with the diphtheria antitoxin and vertically you're streaking the strains. Okay, and this is usually done in times of an outbreak to look for epidemiological relatedness between the strains. And here you can see that a line of precipitation will be formed where the toxin and the antitoxin meet. And whatever test strains that you are putting, depending upon whether those lines they come and meet or whether they cross or whether they form a spur, depending upon that you will know whether the strains are related or not. So here suppose these two lines are actually meeting here, that means that they are related strains. Okay, whereas if there is a spur formation, if there's a partial crossing over like that, then it means that it is partially related strains. Whereas if these continue to cross over completely, then that means that it is an unrelated strain. So this is how you can compare with the previously known strains and the strain that is currently causing the outbreak to see whether there is any relatedness between the strains. So it's a gold standard confirmatory test for toxin production. However, like I said, PCR for tox gene is also a very sensitive and specific molecular test. It's definitely far easier than doing an Ilex gel precipitation test, but the most appropriate one still remains the Ilex. And of course, you can also demonstrate cytotoxicity on cell lines and you can show the toxin detection by ELISA or ICT. So these are some of the other tests to detect toxigenicity. Okay. Then a 45-year-old man presents to the clinic with a 4-month history of persistent cough, night sweats, fatigue, and unintended weight loss of about 10 kilograms. He also reports occasional blood-streaked sputum. He has a history of working in a crowded environment and has not traveled recently. Physical examination reveals mild cachexia and decreased breath sounds over the right upper lobe. Which of the following symptoms is most characteristic of an active pulmonary mycobacterial tuberculosis infection? Okay, just look at how that question went. So he comes to the clinic, he's got all these symptoms, okay, and he's got occasional bloodstained sputum, he's got good degree of weight loss, 10 kilograms of his weight is gone off, he's living in a crowded environment, and when you look, he's mildly cachexic and the breath sounds in the right upper lobe is found to be reduced. So what are the symptoms of classic mycobacterium tuberculosis? Is it recurrent episodes of wheezing? Now, recurrent episodes of wheezing can be seen in asthma or COPD. That does not definitely point to a diagnosis of Mycobacterium tuberculosis. Sudden onset of severe chest pain could be seen in pneumothorax or pulmonary embolism. That does not have to be due to TB. Fever with chills and rigors. Yes, fever with chills and rigors, evening rise of temperature. These are all classically seen in TB. But it is not so much a characteristic of an active pulmonary TB, right? It could also be there in some other viral infections. So that alone, or even other bacterial infections, so that alone is not good enough to substantiate that it is TB. But a chronic cough with bloodstream sputum, bloodstreak sputum is definitely something that should make you suspect active pulmonary mycobacterium tuberculosis infection. So that is the reason why that is the right answer. I hope you're convinced. Okay. So the most characteristic symptoms is cough that is lasts for more than 2 weeks, presence of hemoptysis or bloodstreak sputum, weight loss, night sweats, okay, fatigue, all these are the common symptoms, okay. And when you're seeing it in a person who's living in a low socioeconomic condition or crowded living, unsanitary living, then that should definitely make you think of TB, okay. And the other options, why they are not the best, we have already discussed. Then, a 30-year-old man from a rural area presents to the dermatology clinic with multiple hypopigmented patches on his skin, particularly on his arms and face. These patches are numb to touch. On examination, there is loss of eyebrows and thickening of peripheral nerves. Skin biopsy is performed and acid-fast bacilli are identified within the macrophages. The patient reports a history of similar symptoms in his community. Which stage of Mycobacterium leprae infection is most consistent with this clinical presentation? Is it tuberculoid? Is it lepromatous? Is it borderline? Or is it indeterminate? So there is no doubt that this is leprosy. That is already given in the question. What are the pointers that will tell you what type of leprosy is it? So starting from the beginning, he has got multiple hypopigmented patches. Patches are numb to touch, which means that the nerve involvement is there. There is loss of eyebrows, thickening of peripheral nerves. Again, there is nerve involvement. There's eyebrow alopecia. On skin biopsy, acid-fast bacilli are identified. You're able to see the acid-fast bacilli. And there is a history of similar illness. So when there are multiple lesions, when there is a nerve involvement that is seen, and you're able to see the acid-fast bacilli, you are seeing these eyebrow alopecia, all that points to lepromatous leprosy. I hope there is no confusion. If there is confusion, we will clear it with the discussion. Okay, no worries. So why is it lepromatous? I would say diffuse nature of the lesions, multiple nature of the lesions, the presence of nerve involvement, the presence of AFB, all these will point towards lepromatous. So let's have a look at this table here. Okay. So there is both lepromatous and tuberculoid. Lepromatous is multibacillary. The bacteriological index is 4 to 6 plus, and there are symmetrical lesions with irregular margins. So you have symmetrical lesions with irregular margins, more than six or even more than 6 will be the number of lesions that you get to see. And these lesions could be either nodules or papules or plaques. Okay, all these could be seen in this. And the patient will also have leonine facies and eyebrow alopecia. So These are some of the findings. So symmetrical lesions, irregular margins, nodules, papules, plaque-like lesions which are known as xanthoma, with leonine facies and eyebrow alopecia that will also be seen. Okay, and 6 or more skin lesions will be there. Nerve involvement is usually a late feature, and hyperesthesia is a late sign. 2 or more nerves will be involved. So that is also seen, and the smear will be positive. Whereas if it's tuberculoid, it's paucibacillary, so 0 to 1 would be the bacteriological index, and you'll find asymmetrical lesions will be there, and they will have sharply demarcated borders. So you will have these hypopigmented annular macules will be seen with well demarcated borders and central tendency for central clearings. That's how it will appear. And the skin lesions will be less than 6 usually. Nerve involvement occurs early. Ulnar and post-auricular nerves are the ones that are commonly involved, and nerve abscesses are usually seen with borderline tuberculoid. And at least, nerve involvement is usually one. Only one nerve will be involved, and this will be smear negative. Okay. No worries, we'll discuss a second. Lepromatous leprosy. From the name itself, you should try to remember that it is really leprosy. Okay, it's like really, really very severe. So that means it is multibacillary. The bacteriological index is 4 to 6 plus, and you've got these symmetrical lesions with irregular margins, which could be either nodules. So you have to imagine the what can I say, the deformities that you get to see. So it can be nodules, or it can be papules or plaques with eyebrow alopecia and leonine facies, and more than 6 lesions will be there. But nerve involvement as such occurs late, and 2 nerves at least, okay, will be 2 or even more than that, and smear will be positive. So it's like really leprosy. Then coming to the tuberculoid type of leprosy, it's paucibacillary. The smear is negative. Bacteriological index is 0 to 1. This is the one that you get to see in your clinics sometimes. That is, there will be more of a hypopigmented annular macules, and that will have elevated margins and a tendency for central clearing. Less than 6 in number, that is 5 or below, that will be the ones that are normally seen. And nerve involvement also, only one nerve will be involved. And ulnar or post-auricular nerves are the ones that are commonly involved, and abscesses could also be there. Now, what about the treatment of paucibacillary versus multibacillary? So what all do you call paucibacillary? Tuberculoid, borderline tuberculoid, and indeterminate. These three come under paucibacillary, whereas lepromatous and borderline, these three come under multibacillary. Okay, so tuberculoid, borderline tuberculoid, and indeterminate are pauci. And for paucibacillary, you can give dapsone and rifampicin. Rifampicin 600 mg once a month supervised, and dapsone 100 mg daily self-administered, and the duration of treatment is about 6 months, and follow-up has to be done annually for up to 2 years. Okay. Whereas if it's multibacillary, there is dapsone and rifampicin, same as in pauci, along with clofazimine 300 mg once a month supervised and 50 mg daily self-administered. And the follow-up has to be done for 1 year or until it becomes smear negative. And the duration is for 1 year or until it becomes smear negative, and the follow-up has to be done for or annually up to 5 years. So multibacillary is a much bigger problem. You've got lepromatous, and borderline coming in multibacillary. Okay. So when you say borderline, means they've got features of both. It's a little bit hard to categorize into which one, but it's less severe. And when you say indeterminate, it's a little earlier on in the lesion. There's not that much of a nerve involvement, and as such, there will be fewer lesions. Now, if you also look at the classification, Ridley Chopling, we all know, lepromatous, borderline, borderline tuberculoid and tuberculoid leprosy. Then there is also the Indian classification and the Madrid classification. So in Madrid and in Indian, you've got lepromatous, borderline, tuberculoid and indeterminate. So these, that is lepromatous, borderline, tuberculoid and indeterminate, is seen in both Indian as well as in Madrid. Only thing is there is a pure neurotic type also, which is unique to the Indian classification. Okay. So these three are multibacillary, whereas these two are paucibacillary together with indeterminate. Okay. The next question, a 50-year-old man presents to the emergency department with a sudden onset of profuse watery diarrhea, vomiting and severe dehydration. He reports that the symptoms began a few hours after consuming raw oysters at a coastal restaurant. On examination, the patient appears severely dehydrated with sunken eyes, dry mucous membranes, and a weak rapid pulse. The stool sample is described as rice water in appearance. A stool culture is performed, and the image below shows the bacterial growth on thiosulfate citrate bile salt sucrose agar. You have the image here. Which of the following organisms is responsible for the condition of the patient? Is it Vibrio parahemolyticus, Vibrio cholerae, E. coli, or Salmonella enterica? So the reason why they've given this question and prolonged it so much and given the options of two Vibrios is to create confusion, because here the patient gives you a couple of points which can be confusing. One is he's got profuse watery diarrhea. Okay, that much is clear. He gives a history of consuming raw oysters and he's definitely dehydrated, weak rapid pulse. He's got rice water stools and it is growing on TCBS. Okay, so among these options, Salmonella enterica, no, it does not produce symptoms like this at all. No rice water stool for that. When you see the word rice water stool itself, you know that the answer is Vibrio cholerae. What is it that confuses it with Vibrio parahemolyticus in this question? One is that Vibrio cholerae, how you can differentiate is Vibrio cholerae produces watery diarrhea. Like we mentioned in the previous question, parahemolyticus produces dysentery. Oysters, shellfish consumption and all that can be overlapping between cholerae and parahemolyticus. Even parahemolyticus also definitely associated with consumption of oysters. Then TCBS, what is the color of the colony that you get to see here? See, it's yellow colored colony. Yellow colored colony due to sucrose fermentation is seen with Vibrio cholerae, whereas green colored colonies because of not fermenting sucrose is seen with Vibrio parahemolyticus. So here the answer is Vibrio cholerae. Okay. Then let's just discuss a little bit about the lab diagnosis of cholera. So about the lab diagnosis, freshly collected stool sample is always preferred to rectal swabs. Swabs are usually preferred for carriers. Then you've got transport media, you've got enrichment media, and you've got selective media. Transport media, Venkatraman Ramakrishnan medium, Carey Blair medium, alkaline salt transport medium, and autoclaved seawater. Then direct microscopy, you can see these gram-negative, slightly curved rods that can be seen. They are comma-shaped and they are called fish in stream appearance with darting or shooting star motility as you call them, comma-shaped rods. And culture at 37 degrees Celsius, they are strongly aerobic and they produce a non-specific hemolysis which is known as hemodigestion on blood agar. So sometimes you can be given this image, okay, and you can be asked what is this phenomenon? This particular patient is having such and such a symptoms. This is hemodigestion which is classically seen in Vibrio cholerae. Then enrichment and selective. So enrichment, you've got alkaline peptone water and Mansour's peptone water. So alkaline and Mansour's peptone water, these are the classical enrichment broths. And then selective, you've got TCBS, thiosulfate citrate, bile salt, sucrose agar, sucrose fermentation, yellow colonies. Then you've got alkaline bile salt agar and you've got Mansour's agar as well. I don't try to simply say the Mansour's etc names. It's not important. Just remember Mansour's agar, okay, and Mansour's peptone water. Bas. Then what are the biochemical reactions you get to see? It is oxidase positive. See this violet color that you get to see that usually develops within 10 seconds. Okay, that shows the presence of the enzyme cytochrome oxidase. This is oxidase. This is oxidase positive. Then comes the nitrate and indole, that is nitroso-indole positive. That is what is responsible for the cholera red reaction. So cholera red reaction is nitroso-indole positivity that is seen in Vibrio cholerae. Then string test with 0.5% sodium deoxycholate. Okay, you get a long string-like structure here. This positive string test is also a characteristic feature of Vibrio cholerae. Then parahemolyticus causes gastroenteritis, it more of dysentery, green colored colonies. E. coli will not grow in TCBS, Salmonella enterica will not grow in TCBS, and none of these will produce rice water stools. Will it produce? No. Okay. Absolutely no rice water stools. Next question. A 28-year-old man presents to the clinic with a painless ulcer on his genitalia that appeared about 2 weeks ago. He mentioned that he had unprotected sexual intercourse with a new partner about 3 weeks ago. On examination, the ulcer is firm with well defined borders and a clean base. The patient has no other significant symptoms. A dark field microscopic image from a swab taken from the ulcer is shown below, and you get to see something there that looks like a spring, isn't it? Which of the following is a most likely mode of transmission of the organism identified in the image? Is it blood transfusion, sexual contact, vertical transmission from mother to child, or contaminated water? Okay, so this is a man who's had an unprotected sexual intercourse. And he's coming with a painless ulcer that has got a clean base and well-defined borders, no other symptoms, okay? And on dark field microscopy, you are able to see something that is spirally coiled. And what is the most likely? So what are we discussing here? This is a case of primary syphilis. Yes. Any doubts as to why it is primary syphilis? Because you've got an ulcer on the genitalia. That's a painless ulcer with a clean base, firm. All those are classical findings together with a history of unprotected sexual intercourse and a dark field microscopy showing a spirally coiled organism, everything pointing towards Treponema pallidum, which causes syphilis. Now the question here is, what is the most likely mode of transmission of syphilis? Is it blood transfusion, sexual contact, or vertical? Anyway, it's not through contaminated water, that we all know. All these three options can transmit syphilis, but the most common mode and the mode pertinent to this question is through sexual contact. Okay. So it's primarily something that is transmitted through sexual contact, okay, which includes direct contact with a syphilitic sore by anal, oral, or vaginal sex, whichever way that it happens. And vertical transmission can occur, but not here. And blood transfusion used to be a very important method, but not now with the onset of good screening processes. Now that we have discussed syphilis, let's talk a little bit about, what all you get. This is a direct microscopy. Yes, secretions or swabs from the lesions can be used for direct microscopy. And you get these slender, spirally coiled, organisms which are flexible. And you can also see the motility, which is classically corkscrew motility. Why does it have that motility? Because it's got something called as the endoflagella. So endoflagella are responsible for the corkscrew motility. And direct fluorescent antibody staining, that is very 100% sensitive, something that is done with the fresh sample. So direct fluorescent antibody staining for Treponema pallidum. Then to increase the thickness, you can also do a silver impregnation, and Fontana and Levaditis staining can be done. So that way also you can see it. Then there are other tests like serological tests. So serological tests could be either non-treponemal or treponemal test. So non-treponemal test is when you're using a non-specific cardiolipin antigen to detect the reagent antibody. So it's detecting a reagent antibody, which is again non-specific, and is using a cardiolipin antigen. And it's primarily used to look for response to treatment, and there is a possibility of a biological false positives. So VDRL and RPR are the most common non-treponemal tests that I use. Both are slight flocculation tests, but VDRL is microscopic whereas RPR is macroscopic, and CSF can be processed on VDRL but not on RPR. So RPR is not for CSF. Okay. Then there are others also. You leave that. Just remember, non-treponemal uses reagent antibodies. It's non-specific. It is used to check for response to treatment. There's a possibility of BFPs, and VDRL and RPR are prototypes. Treponemal test uses specific treponemal antigen to identify the specific treponemal antibody. There are different tests like TPI, TPHA, TPPA, and FTA-ABS, of which it is the most sensitive and specific test, for all stages of syphilis is FTA-ABS. And for congenital syphilis also you can use, for CSF sample also you can use, and it's also the first serological test to become positive. So that's one very, very important aspect about FTA ABS. Okay, so Directly also you can do direct microscopy, direct fluorescent antibody staining, Fontana's and Levaditis, okay, for tissue and all that stuff. Then you can also do the treponemal and non-treponemal tests. And what are each? What are the advantages? What are the problems? Let me take a sip of water. Coming to the next question. A 35-year-old man presents to the clinic with a painful vesicular rash localized to the right side of his chest. The rash appeared 2 days ago and follows a dermatomal pattern. The patient reports a history of chickenpox as a child. A Zank smear is performed from the base of the vesicle and the image shows a multinucleate giant cells. Which of the following is the most appropriate confirmatory test for identifying the causative agent of this patient's condition? Is it direct fluorescent antibody test? Is it a Gram stain, RPR, or ELISA for EBV? Okay, so it's very clear that this patient has a painful vesicular rash, okay, and it's got a typical dermatomal pattern. He's giving you a history of chickenpox when he was a child. And when you do a Zank, you're getting these multinucleate giant cells. So what is the condition that we're discussing here? Somebody who has had chickenpox in childhood getting a very painful vesicular rash, which is distributed across dermatomes. It's herpes zoster, okay? So it's a herpes zoster infection. So how can you, what is the most appropriate confirmatory? How can you confirm this diagnosis? That is the question. So what is the most appropriate confirmatory test? It is it the enzyme linked immuno? Why would you do an ELISA test for EBV? That is not going to help you at all to identify the varicella zoster virus. Here we're discussing VZV. Okay, then RPR is for syphilis. It's got nothing to do with, let me just mark that one. RPR is for syphilis. It's got nothing to do with varicella zoster. On Gram staining, you can see the bacteria, but you can't see any virus. So that is also not the answer. Direct fluorescent antibody staining. Again, you are directly detecting the presence of this antigen. So that is an excellent method. It's sensitive and specific. And that is a test which can be used as the confirmatory test. Okay. So Zank shows multinucleate giant cells that is consistent with herpes infection, but whether or not it is HSV or VZV, that difference is something that you cannot make. And I think from an entrance aspirant's perspective, you have to understand the importance of this direct fluorescent antibody testing. That is something that is very sensitive and specific, you know, and clinical samples. See, you're directly detecting the viral antigens. That is so definitive. So every time you see a question with this answer as one of the options, that is direct fluorescent antibody, you must think whether just by doing that test, you'll directly be able to say whether it is a particular viral antigen, because it is so definitive. That is what makes it a very good confirmatory test. Okay. Gram stain, no. RPR, no. And definitely not enzyme linked immunosorbent assay for EBV. That's not going to help you at all. Next question. A 55-year-old man is admitted to the hospital with symptoms of severe watery diarrhea, abdominal cramps, and low-grade fever. He recently returned from a trip to a developing country. Stool cultures revealed the presence of E. coli O157, a strain known to produce Shiga-like toxin. Which of the following is the most appropriate treatment and management strategy for this patient? Initiate broad-spectrum antibiotics immediately. Administer anti-motility agents to control the diarrhea. Provide supportive care with rehydration and avoid antibiotics. Administer oral vaccines as prophylaxis for close contacts. So one thing is certain, this person also has a food poisoning because he's just come back from a developing country with watery diarrhea, abdominal pain, and low-grade fever. And stool cultures are revealing E. coli O157, which is known to produce Shiga-like toxin. So this is definitely a toxin-mediated, E. coli diarrhea that we're discussing here. So in such a case, does initiating broad-spectrum antibiotics help? No, that's not going to really make any difference in such a situation at all. Then suppose you give anti-motility agents, what is going to happen is that the toxin exposure will continue for a longer time. You want the toxin to go out or stay there. So you can't give anti-motility agents. In fact, for no type of diarrhea are anti-motility agents ever really, indicated. And all that you can do is to give supportive care with rehydration and avoid antibiotics. And you cannot administer oral vaccines because it's got no role in the management of any of the contacts. So administration of oral vaccines is not a method. Another way, if you're confused, you just have to remember that one option says give broad spectrum antibiotics, the other option says do not give antibiotics. So these two options, one of these should definitely be the answer. So you can eliminate the other two options, and you must look at it, whether it's a toxemia or a bacteremia that we're talking about. This is a toxin mediated condition in which antibiotics are not going to be able to do much. Once the toxin production has happened, then antibiotics cannot do anything to prevent the development of symptoms. So this is E. coli O157H7, okay? That is enterohemorrhagic E. coli. It is a toxigenic strain, but it is non-invasive. So it is mainly seen in industrialized countries. And we said that in the question also it's mentioned, it is a toxigenic one, Shiga-like toxin or virotoxin or virocytotoxin. That is the one that is primarily responsible for this condition, and it goes and binds to the globotriacyl ceramide receptor, that is a GB3 receptor, and inhibits protein synthesis. It has got a predilection for the endothelial cells, and it can cause microangiopathy, and the clinical manifestations include hemolytic uremic syndrome and hemorrhagic colitis. And the contaminated food includes lettuce, sprouts, beef. So all these could be implicated. And to diagnose, it can be cultured on sorbitol McConkey agar. This enterohemorrhagic E. coli does not ferment sorbitol. Then you can do the ELISA test to detect the toxin. You can do a PCR to detect the toxin, and you can also demonstrate the cytotoxicity on Vero cells or HeLa cells. So there are different things that can be done. You can do the ELISA, you can do the PCR detection, cytotoxicity demonstration, and sorbitol McConkey agar is very, very important for to demonstrate this. That's one special medium because it does not ferment sorbitol. Remember, EHEC, that is O157H7, is known to produce a Shiga-like toxin or the virocytotoxin. GB3 receptor inhibits protein synthesis. It's got a predilection for or a special affinity for endothelial cells, so it can cause microangiopathy. And HUS and hemorrhagic colitis are the usual manifestations. So antibiotics normally we do not give. Anti-motility agents are also contraindicated, and vaccines also do not have any relevance. The next question. A 50-year-old man presents to the emergency department with a 3-day history of headache, fever, myalgia, and a dry cough. He reports that several of his co-workers have had similar symptoms recently. On examination, he is febrile with a temperature of 39 degrees, and auscultation of the lungs reveals scattered rhonchi, but no signs of consolidation. Given the clinical presentation, the physician suspects an influenza virus infection. Which of the following tests is most appropriate for a rapid and accurate diagnosis of influenza virus infection in this patient? Is it the rapid influenza diagnostic test, chest X-ray, CBC, sputum culture? So again, a question which is asking you for the best diagnostic tool that can be chosen. So a 50-year-old man, he comes to the emergency department with some symptoms of an upper respiratory infection, fever, headache, myalgia, with a report that many of his co-workers, so it's something which is very contagious, and he is also having fever and some scattered rhonchi. The clinician thinks it is influenza. Now, which of the following test is most appropriate for a rapid and accurate diagnosis? So, sputum culture is not going to give you influenza virus. CBC is not going to tell you anything much about it. Chest X-ray also will not be very specific because you want the rapid and accurate diagnosis. And these three are, sorry, it's not star. I'm getting too used to drawing the stars. So these three are not the options. It is rapid influenza diagnostic test. What do you do in this test? In this test, you detect the antigen. It's very quick, very accurate. So that is the one that we use. So the rapid influenza diagnostic test is what is run on patients in whom you're they show features which are highly suggestive of influenza, and you want a very quick and rapid diagnosis, at the same time accurate. So RIDTs, they can provide the results within 15 to 30 minutes, and that can be performed on respiratory secretions, either a nasopharyngeal swab or a secretion that can be used, and you're looking for the antigens for influenza A, and you get a very quick diagnosis. Of course, the gold standard would be the PCR, that is for the RNA detection, okay, but that will take time and that is costly as well. So that is a confirmatory one. Whereas all the other tests which are mentioned in the question, they are not specific, okay, for influenza. So rapid influenza diagnostic test or PCR for influenza, one of these two tests can be done. Then some other extra points, okay. So one thing about influenza is it's never asymptomatic, okay. It's very rare. Most of the patients will be presenting with something like a upper respiratory tract infection and diarrhea. That is what is known as influenza-like infection. Influenza-like illness, that's what it's called. So URTI and diarrhea, and the incubation period is about 1 to 3 days. And normally what happens is that pandemics are rare, okay? That usually happens only once in 10 to 15 years. And how does it persist in the community? Through a variety of birds and animals, okay? That's how it manages to persist. And the attack rate is equal for all ages and all sexes, but there is definitely an increased predilection for children less than 2 years, adults more than 65 years with some underlying disease like diabetes, COPD, heart, liver, lung infections, and so on. So these are the ones in which it is more. And in general, it will attack all ages and all sexes, but it's slightly lower in adults compared to these extremes, okay? And among these high-risk population, there's high chance of complicated infections developing. And this is exactly why in these categories, there could be secondary bacterial infections and sepsis with multi-organ dysfunction syndrome, all these secondary bacterial pneumonia, secondary bacterial sepsis, MODS, neurological involvement, all of them presenting what is known as SARI, that is severe acute respiratory infection. So what I'm trying to tell you here is, if they say that something could it be asymptomatic, that's totally wrong. It cannot be. Usually presents as an upper respiratory tract infection and a diarrhea, that is an influenza-like illness. But in the population with a predilection for these complications, like less than 2, more than 65, with all these underlying conditions, that is where the pneumonia can classically develop into a secondary bacterial pneumonia, secondary sepsis with multi-organ failure, neurological involvement, and that is the one that presents as SARI. And pandemic is relatively rare. It's usually there in the environment because of these reservoirs like birds and animals. The next question. A 40-year-old man presents to the clinic with fatigue, jaundice, and upper right quadrant abdominal pain. He has a history of IV drug abuse and several tattoos. His liver function tests are elevated and a hepatitis panel is ordered. The serology results shows positive HCV RNA and positive anti-HCV antibodies. Which of the following best describes the most likely mode of transmission of hepatitis virus in this patient? Is it fecal-oral? Is it bloodborne? Is it airborne? Or is it sexual transmission? So this is a man who is coming with jaundice, fatigue, and upper abdominal pain. He gives a history of IV drug abuse. He's got several tattoos. His liver function tests are deranged, so they order a hepatitis panel, and he's got HCV antibodies positive on ELISA, and HCV RNA is also positive. So the question here is, what is the most common mechanism of transmission of hepatitis C? So two of these can be taken out. One is it is not airborne and the other one is it is not fecal-oral. So both sexual transmission and bloodborne transmission can occur. But in this particular patient, it is always a bloodborne transmission that is more likely. Okay. In general, for hepatitis C, bloodborne transmission is more than vertical, and that is more than sexual. So sexual can occur, but the degree of transmission is much lesser. So here it is not sexual, it is bloodborne. Even otherwise, with his history also, it is through IV drug abuse. So again, it has to be bloodborne and not sexual. So hepatitis C is primarily transmitted through bloodborne routes, okay, such as IV drug abuse and blood transfusions. Before screening became so good, through use of unscientific, tattoos and other paraphernalia, we don't know how clean it is, okay. So sharing of needles, all that can be an important source of transmission. Fecal-oral transmission, like we said, is not for hepatitis B. It could be for hepatitis A or E. And airborne transmission is not a route of transmission for hepatitis virus at all. Sexual transmission is possible, but the risk is theoretically much lesser, especially considering the history of this patient. Then regarding hepatitis C, some other points that I want you to quickly recollect is it's caused by a flavivirus, that is a Hep C virus, single-stranded RNA virus. It shows a high degree of diversity of the RNA because of the high rate of replication and the lack of proofreading activity of RNA polymerase. There are 6 genotypes, of which 1 and 2 are more common in the West and 1 and 3 are more common in India. And more than 100 subtypes are also there and shows quasi-species of variation. Transmission most common is parenteral. This is followed by vertical, and then only there will be sexual transmission. 75% of the patients will be asymptomatic and the remaining will show features of acute hepatitis. Of these, 5 to 15% will show spontaneous clearance and the remaining can become chronic. Okay, so around 5 to 15% only will show spontaneous clearance. So, the high degree of chronicity for hepatitis C. And chronic can be chronic hepatitis, or it could be cirrhosis, or it could be hepatocellular carcinoma. One of these, whichever one of these it can be. Then extrahepatic manifestations, okay, extrahepatic manifestations could be mixed cryoglobulinemia, acute glomerulonephritis, arthritis and joint pains. And in general, the testing sequence is HCV ELISA, which is followed by the HCV RNA PCR. And this is the normal mode of testing for adults over the age of 18 years and pregnant women in areas where the prevalence is more than 0.1%. But if it's a high risk group that we are targeting, don't bother to look at the prevalence or whatever area it is. You just have to do this test itself. And biopsy is the gold standard for staging hepatitis C virus infection. So these are the different points that I want to tell you about this. It's got a high rate of genetic diversity. It shows quasi-species variation, and 75% may be asymptomatic and only 25% presence of acute hepatitis. Of these, about 15% can get spontaneously cleared, but the chronicity possibility is much higher in hepatitis C as compared to hepatitis B. And parenteral is the most common route of transmission, followed by vertical, followed by sexual. And HCV ELISA followed by RNA detection is what is normally the protocol which is followed. Okay. The next question. A 30-year-old healthcare worker presents for evaluation after a needle stick injury sustained while drawing blood from a patient known to be positive for hepatitis B virus. The healthcare worker completed the full HPV vaccination series several years ago, but her antibody status is unknown. An initial blood test shows that her hepatitis B surface antibody titer is 8 milli-international units per ml, whereas the predicted level should be more than 10. What is the most appropriate next step in the management of this healthcare worker? Administer a single booster dose of hepatitis B vaccine, administer hepatitis B immunoglobulin only, administer both immunoglobulin and a booster dose, no treatment, observe and monitor. So this is basically to know how well we know the needle stick injury management policies. This particular lady has had a needle stick injury, okay, that was sustained while drawing blood from a patient which is known to be positive. And she already positive patient, and she has taken the vaccination, but her titer is not known. So her antibody status is unknown. And when she checks the titer, it's only 8, whereas the predicted titer should be more than 10. So in other words, she is not protected and she's had a needle stick injury from a positive person. So in such a case, would you just let her go off? Absolutely not. Would you give her only the vaccine? No, because vaccine does not give immediate protection. It only gives long-term protection. Would you only give her immunoglobulin? No, that would only solve the immediate problem. But you also want the long-term. So you will give her immunoglobulin plus a booster dose of the vaccine. Okay, I hope you understood this. If not, I'll show you the protocol. So the main idea behind this is that hepatitis B immunoglobulin gives passive immunity, booster dose gives active immune response. So this is the table which we are discussing. This we don't want. You are not going to get any question from this segment. So you leave that. So vaccination status and antibody response status of exposed healthcare workers. Suppose the healthcare worker is unvaccinated. Okay, there are two categories of exposure. B positive patient and B negative. So if it's an unvaccinated, you have to give immunoglobulin and you have to initiate the series of vaccinations immediately, no doubt. And if it's an unvaccinated person in whom the source is negative also, you have to initiate the vaccination series immediately because you don't want to take a chance with such a person. No need to give any immunoglobulin though. Okay? Because the source was negative. So if source is positive, HBIG plus vaccination series start. Source is negative means vaccination series start. Okay. In a previously vaccinated non-responder, somebody who has responded, whether the source is positive or negative, nothing more need to be done. Okay. Whereas someone who is a known non-responder, suppose the source is positive, you have to give an immunoglobulin and then you can either initiate revaccination. Okay, that is what you normally do. So if it's a non-responder, you will give immunoglobulin and you will initiate the revaccination. Whereas a known non-responder, okay, in whom the source is negative, ideally you don't have to give any treatment. Okay, so this is where there is a slight confusion because even though he is a known non-responder and he does not have any the source is negative also, it is ideally better to start another fresh vaccination series. Okay, you have to first give him a booster and then you can even restart another set of vaccination series. So here there is a slight degree of question mark on this protocol, but this is a CDC protocol. Then suppose the antibody response is not known. So in that case, you will first look at the titer, and if the titer is adequate, you will not do anything. The titer is low, you will start with the hepatitis immunoglobulin and you will give a vaccine booster, which is what we have done in this patient. So whoever has taken a hepatitis B vaccine should ideally have their antibody response known. If it's a known responder, don't do anything, whether they're positive or negative, the source, that doesn't matter. If it's a non-responder, if the source is negative, then you don't have to do anything. But if the source is positive, in that case, you have to give immunoglobulin and then you have to start the fresh revaccination. Suppose the titer is not known, you check the titer and then if they are responded, then nothing more to be done. If they do not respond, then you have to give them hepatitis B immunoglobulin and one booster dose. Okay. And following needle stick injury, the chances of transmission of hepatitis B is more than hepatitis C, is more than HIV. That is 30% chance for hepatitis B, 3% chance for hepatitis C, and 0.3% chance for HIV. Okay, that is very, very important to know. So suppose you only give a booster, you're only looking for the long-term immunity, the immediate protection is not there. Suppose you only give immunoglobulin, only immediate protection, long-term protection is not there. Okay. So that is the reason why you have to give both. Definitely no treatment is not an option because that's a positive patient and a healthcare worker who is not protected. So that's not something that you can do. A 30-year-old man presents to the emergency department after being bitten by a stray dog while jogging in a rural area. The bite is deep and located on his right calf. The dog ran away after the incident and its rabies vaccination status is unknown. The patient has not received any prior rabies vaccination. He is concerned about the risk of rabies. What is the most appropriate prophylactic treatment for this person? No treatment is necessary. Clean the wound thoroughly and observe the dog. Administer rabies vaccine alone. Administer rabies immunoglobulin alone. Administer both vaccine and immunoglobulin. Okay. So here there are multiple pointers that tell you how risky the bite was. Okay, one is he was bitten by a stray dog. It was a deep bite. It's located on his right calf. The dog has gone away. The rabies vaccination status of the dog is unknown. He has never received any rabies vaccination. So all in all, it is a category 3 bite, right? Because it is a it's a deep bite. It's by a stray dog. You do not know the vaccination status. And this guy also has not taken any prior vaccination. So no treatment, just clean the wound is absolutely not possible because you don't even know where the dog is and you have to treat such a deep wound. Suppose you give only the rabies vaccine, again, just like in the previous question, you're only concerning yourself with the long-term protection, but immediately unless you protect, there is no point in giving the vaccine. Just by giving the immunoglobulin, it's just passive immunity, it's just immediate, that will not do. You also need to have some degree of active immunity. So here you have to administer both the rabies vaccine and the rabies immunoglobulin. That is the right answer. Okay, so because the right approach would be to include both passive and active immunization. So categories of contact with suspected rabid dog and post-exposure prophylaxis. What I would suggest is that you learn only category 1 and 2 and think that everything else is category 3. So what is category 1? Touching and petting of animals and licks on intact skin. Okay. In such a case, you don't have to do anything. You can just wash up and you can just go. Okay. Touching and licking and feeding of animals and licks on intact skin. Category 2 is nibbling on uncovered skin and bites or scratches without bleeding. Okay, so nibbling on uncovered skin and bites or scratches without bleeding. In that you must give a wound care and you must start vaccination as well. So wound care and vaccination. Whereas anything else that is transdermal bites, scratches, you can't follow up the animal, contamination of mucous membrane, contact with bats. For all this you must do local treatment. Then you've got to do the vaccination and you have to give the immunoglobulin as well. So if it's just a category 1, it's not wound care, it's basically just, only hand wash because there's no real wound there as such. So you can just do a hand washing and the local cleaning, that is enough. Whereas it's category 2, you have to give both wound care and vaccine but no immunoglobulin. If it's category 3, you must do all wound care, vaccine and immunoglobulin. Immunoglobulin is passive and immediate and vaccine is active and long term. This is the point that you have to push through. So no treatment is not enough, vaccine is not enough, RIG is not. What are some of the other things that you should know about rabies vaccination? So rabies vaccination, it's a non-neural vaccine basically. Neural types had lots of problems, so that's no longer being used. And among the non-neural vaccines, you've got purified chick embryo cell, purified vero cell, and human diploid cell culture vaccines. Okay, so chick embryo cells from fibroblasts, vero cell is from vero cell, and human diploid is WI38. That is what is being used. And you've got the routes are intradermal and intramuscular, of which intramuscular you give the entire vial, whereas intradermal you give only 0.1 ml. And the site is either on the deltoid or on the anterolateral aspect of the thigh. It's never given in the gluteal region. So intradermal is a two-site intradermal vaccine is there. So it's 222, that is 0, 3 and 7. So that is a 222 vaccine, that is IDPEP, that is in 2 site, 2 doses on 2 sites, and that is 0, 3 and 7. Whereas the intramuscular, there are 2 protocols. One is 0, 3, 7 and 14 to 28, that is 1 dose. 1 site IM is there, and the 2-site IM is on day 0 you give it at 2 sites, and after that on day 7 and 21 you just give it as 1 site IM. Okay, and during the course of vaccination you can change over from intramuscular to intradermal, that's not a problem. And suppose you miss a particular dose also, you don't have to restart the vaccination, you can just continue from where you have left off. Okay. So purified chick embryo cell, vero cell and human diploid cell culture vaccines, and intradermal and intramuscular, do not give it on gluteal. Intradermal is 222 on 037. Intramuscular is 1 site IM is 037 and 14 to 28, 1 last dose. Whereas intramuscular 2 site on day 0 and then 1 site on day 7 and 21. Okay, the reason I have discussed this is because the areas immediately near to this is the ones from where the next set of questions can probably come. That's why I have taken a little time to again go back to this vaccination. Then, a 40-year-old HIV positive man presents to the clinic with complaints of progressive shortness of breath, dry cough, and fever over the past 2 weeks. He reports not being compliant with his ART. His CD4 count is 100 cells per microliter. A chest X-ray is performed and the image is given below. You can see these bilateral infiltrates, right, throughout the chest X-ray. And based on the clinical presentation and chest X-ray findings, which of the following opportunistic infections is most likely to be affecting this patient? Okay, is it pneumocystis jirovecii, CMV, tuberculosis, or aspergillus? Okay, so this is the X-ray of a patient who is having, who's on ART but who has defaulted, and currently his CD4 count is less than 100, and he's having a lot of some respiratory symptoms. So which is the most likely opportunistic infection? So because of this presence of these interstitial infiltrates, okay, characteristic chest X-ray findings showing these bilateral interstitial infiltrates, that is the reason why it is pneumocystis jirovecii. Now, why it is not the other options? We will discuss that at the end of this question. So, the patient has shortness of breath, low-grade fever and cough with low CD4. And pneumocystis jirovecii is very much common when the CD4 count goes below 200. That is when this opportunistic infection comes into play. And if you look at the pathology, you get a foamy vacuolated exudate. That's why it's known as interstitial plasma cell pneumonia. Okay, it's a typical foamy vacuolated exudate that you get to see. And in severe disease, there could be interstitial edema, there could be hyaline membrane formation, fibrosis, but there is never any ARDS. So ARDS as such is not seen with pneumocystis jirovecii. And for lab diagnosis, you have to send either the biopsy or the BAL samples. And when they are stained with GMS, that's gomori methenamine silver, you get this crushed ping pong balls against a black background. That is a classic, against a green background, sorry. And that is a classical finding that you get to see in the GMS stain of pneumocystis jirovecii. This is a non-cultivable bacteria, so you can either look for the specific genes or you can do the beta-D glucan in serum. And radiologically, CT will show this ground glass opacities, and the drug of choice for treatment is cotrimoxazole. And if it's a non-HIV associated patient, then you can treat for 2 weeks, whereas if it's HIV associated, you have to give it for 3 weeks. Okay. So pneumocystis jirovecii, GMS staining showing crushed ping pong balls appearance against a green background. Then you also get ground glass opacities, bilateral, you get these interstitial infiltrates, you get a foamy and vacuolated exudate. There's never any ARDS that is seen. You can do a beta-D glucan, but unfortunately this is not cultivable and the drug of choice is cotrimoxazole. Then cytomegalovirus pneumonia can also occur in immunocompromised patients, but it's definitely less likely compared to PCP. And this typical bilateral infiltrates is not seen with CMV pneumonia. Tuberculosis means it will be more in the upper lobes and will have a more of a cavitatory type of a lesion. It will not be seen like this. Aspergillus also is usually seen in the upper lobes. Okay, it can present as a cavitary lesion and also sometimes as a fungal ball. So cavitating lesions or fungal ball is what is a normal presentation of aspergillosis. I'll just take a 2-minute break and come back. So before I go to the next question, there was a query which was who is a responder? So what do you mean by a responder is someone who has taken the hepatitis B vaccine, the 3 doses of the vaccine. You know that the normal schedule is 0, 1 and 6, right? So someone who has taken the vaccine and whose anti-HBs titer is more than 10. Such a person is a responder. Whereas a non-responder is someone who has taken the 3 doses of the vaccine and still who does not have an acceptable titer. Okay, that is a titer of 0 whose titer still remains at 0. Such a person is known as a non-responder. So that is the difference between a responder and a non-responder. So now let's go to the next question. A 32-year-old man presents to the emergency department with a 4-day history of high fever, severe headache, retroorbital pain and myalgia. He recently returned from a trip to Southeast Asia. On examination, he has a diffuse maculopapular rash and a positive tourniquet test. Laboratory tests reveal thrombocytopenia and elevated liver enzymes. The physician suspects dengue fever. Which of the following is the primary mode of transmission for the infection suspected in this patient? Is it a bite from an infected Anopheles mosquito or a bite from an infected Aedes mosquito, contaminated food or water, or direct contact with an infected person's blood? So one look, it's a relatively simple question. Like everything is already given here. It's coming to the emergency with a history of fever, headache, retroorbital pain, myalgia, has traveled to Southeast Asia where you get a lot of cases. And again, maculopapular rash, a positive tourniquet test, thrombocytopenia, elevated liver enzymes. It's a very direct short answer, it is dengue. And what is the primary method of transmission of this infection? You know, it's because of the bite of the Aedes mosquito, right? None of the other options fit the bill. It's not direct contact with an infected person's blood. It's not through contaminated food or water, and it's not through the bite of an infected Anopheles mosquito. Okay? So it's from the bite from an infected Aedes mosquito, and dengue as such is the most common arboviral infection that is found in India. It's a flavivirus infection. It's caused by a single-stranded RNA. And dengue 1 to 4 serotypes, you know, they will be existing between man and the mosquito, that is the only reservoir, whereas dengue 5, the 5th serotype, that has got a sylvatic cycle as well. Okay. And the most common vectors are Aedes aegypti and Aedes albopictus. And both these vectors are day-biting mosquitoes. The extrinsic incubation period is around 10 days. And once this gets infected, the mosquitoes are infected for life because even transovariant transmission also happens. So that is how it maintains its levels even during the interepidemic period. Okay. That is how it survives. So once a person is infected with one serotype, he becomes immune to that particular serotype, but he is still susceptible to infection by any other serotype. So if there's been an infection with dengue 1, then 2, 3, 4 again the person can get. And a second infection is always the more severe one, and that is because of this antibody dependent enhancement. And it is the second time infection that normally manifests as dengue hemorrhagic fever or dengue shock syndrome. So usually it presents as a mild infection that could usually be the first infection with a particular serotype. A repeat infection is what manifests as hemorrhagic fever or shock syndrome. Okay. And in general, children less than 12 years are more prone to develop this hemorrhagic fever and shock syndrome. So here this patient's clinical features, his positive tourniquet test, and of course thrombocytopenia with elevated enzymes, everything points towards a dengue fever. So mostly it's mild, mostly it is self-limiting. Okay, that's how majority cases are, but only in the repeat infection with a different dengue virus serotype does the problem of hemorrhagic fever or shock syndrome usually happen, and children are definitely more vulnerable to this than adults. Okay. Then the other options like Anopheles mosquito is mainly for malaria, contaminated food and water, nothing has to do with dengue. Okay, direct contact with patient's blood also is for HIV, hepatitis B and hepatitis C. Then let's discuss one question from mycology now. A 26-year-old woman presents to the dermatology clinic with complaints of hypopigmented patches on her upper back and shoulders. She mentions that the patches became more noticeable after sun exposure and have been present for several months. The affected areas are slightly scaly but not itchy. She has no significant past medical history and is otherwise healthy. A potassium hydroxide, that's a KOH preparation of the skin scrapings, reveals spaghetti and meatball appearance under the microscope. Which of the following organisms is most? Is it Trichophyton rubrum, Malassezia furfur, Candida albicans, or Microsporum canis? So that's a pretty direct question there too. Okay, she comes with these hypopigmented patches. These are all points that you have to remember. Hypopigmented patches on her upper back and shoulder. And she says it's more after sun exposure, and the affected areas are slightly scaly, but they are not itchy. Okay, and she has nothing significant, and in KOH it shows spaghetti and meatball appearance, which is so classic of this organism. And spaghetti and meatball appearance is not shown by Microsporum canis, Candida albicans, or Trichophyton rubrum. It's only shown by Malassezia furfur. Okay. So what is this condition that we're looking at? It is tinea versicolor, otherwise known as pityriasis versicolor. Okay. So what is it actually? It's a chronic recurrent condition of the scrotum corneum. It will keep on going and coming. It's a recurrent condition and it's caused by Malassezia furfur, which is a lipophilic fungus, and it is characterized by either hypo or hyperpigmented patches. Okay, that could be scaly and that is non-inflammatory, non-pruritic, non-itchy, none of that. Okay, so it could be flat or round, scaly, hypo or hyperpigmented patches, and that commonly they are seen in the neck, chest, and in the arms. That is the common area. See these images here. It's very typical. Okay, you've got these hyperpigmented or these hyperpigmented. Okay, either way they can be presenting, and scaly but not itchy. Okay, whereas the DD would be vitiligo. Vitiligo is actually not scaly. And there are other manifestations also for Malassezia furfur. It can present as seborrheic dermatitis. Seborrheic dermatitis of the scalp is what we commonly call as dandruff, or as cradle cap in infants, and that is itchy. Okay, so that will be pruritic. For seborrheic dermatitis will be pruritic, and otherwise it can also cause atopic dermatitis, folliculitis. So there are different manifestations, but remember seborrheic dermatitis and tinea versicolor. Tinea versicolor is scaly, non-itchy. Seborrheic dermatitis is itchy. Okay, pruritic and scaly both. Then 10% KOH showing spaghetti and meatball appearance. So this is the image here. You have these looking like meat balls, and here this is looking like spaghetti. Okay, so this is spaghetti and meatball appearance. And when you do a sabrose dextrose agar culture with olive oil overlay, it's got some specifications for Malassezia furfur. So olive oil overlay on STA, you get a fried egg colony. It also shows a positive urease test and a golden yellow fluorescence on Woods lamp. And treatment is with ketoconazole or terbinafine cream, selenium sulfide shampoo, and everything should be used for 2 weeks. So you need to give a therapy for 2 weeks. Okay, it's urease positive, spaghetti and meatball appearance on 10% KOH, Woods lamp golden yellow fluorescence, and SDA with olive oil overlay showing the fried egg colony. Okay, that is Malassezia furfur. Now, Trichophyton rubrum, that is a dermatophyte that can cause infections, okay, but it does not present with spaghetti and meatball. Then Microsporum canis, again, that is causing ringworm infection. That's also dermatophyte, no spaghetti and meatball there too. Candida albicans just causes mucocutaneous candidiasis, no spaghetti and meatball there too. Okay, so that's how you roll out all those options. Then, a 55-year-old man presents to the clinic with a 2-month history of cough, fever, night sweats, and weight loss. He recently returned from a trip to the Ohio River Valley. A chest x-ray reveals multiple nodular opacities in both lungs. A biopsy of one of the lung nodules is performed and the histopathological examination is shown in the image below. You are seeing something there in the histopathological image, isn't it? So based on the histopathological findings and the clinical history, which of the following organisms is most likely responsible for this patient's infection? Is it Histoplasma capsulatum, Coccidioides semitis, Blastomyces dermatitis, or Paracoccidioides brasiliensis? Now this is a reasonably difficult question because all of them are dimorphic fungi. All of these fungi are, three of them are not found in India. One is still found in India, but that is also found in that place which is specified in the question. Okay, so that means ruling out any one of these options is only possible if you know the histopathological appearance of all of these, right? Let's go back and have a look at the question. So he comes to a clinic with a 2-month-old history of fever, cough, night sweats, and weight loss. He's recently returned from a trip to the Ohio River Valley. Chest X-ray shows nodular opacities. Okay, and from the biopsy, what is there in the histopathological examination? So here you can see single, broad-based budding. You can see the budding, yes. Okay, it is broad based budding, and some of these they almost look like figure of 8. Do you think that it looks like a figure of 8? Okay, and some of these walls, they also appear double contoured. Do you agree with me? So this one thing is that it's broad-based budding, right? Look at the budding. It's broad-based budding, double contoured wall with a figure of 8 appearance, and that is classically seen in blastomyces dermatitis. Okay, so the systemic fungal infection. He has history of travel to a place from where he can have gotten the infection. His clinical features are nodular opacities that he gets to, nodular, lesions that he gets to see. And the biopsy finding is what gives it classical. So, single broad base, double contoured wall, figure of 8 appearance. So, it is a dimorphic fungus, okay? And it's endemic in regions of Ohio and Mississippi River valleys, but it is not the only one. That is where the confusion starts. Okay, and it's endemic in North America, and mode of spread is through inhalation of conidia, and BAD1 is the glycoprotein which is expressed in the yeast phase. Pulmonary blastomycosis is the most common form of the infection. Treatment is liposomal amphotericin B. And this again is a histopathological image wherein you can see, at least I can show you one good one. Can you make that one out? Yeah, that's looking like an 8, okay? Figure of 8 with broad-based budding. That word, broad-based budding, double contoured wall with figure of 8, blastomyces. As it is, can't you remember blastomyces? You write it as a B, right? So I kind of like to think of this as the broad-based budding, okay? Broad-based budding. And that B also can be converted into an 8 if you want. So it's got a figure of 8 appearance. Okay, so try and remember it like that. Something like that might probably help you to remember that better. Yeah. Then comes histoplasmosis. Like I said, that's histoplasmosis is very close to this as far as the history clinical features are concerned in this question. It's again a dimorphic fungus. It's known as Darling's disease. Okay, that's Histoplasma capsulatum. It is seen worldwide, but it's endemic in Ohio River and in Mississippi valleys. There it is extremely commonly seen. In India also this condition is seen. In India also this is seen in West Bengal along the river Ganges, because that is where you have this abundance of bird droppings, and at the same time it's humid as well. So when you inhale the spore, this microconidia, they will be getting engulfed by the alveolar macrophages. There they will convert into the yeast form. They survive within the phagolysosomes of the macrophages, and they travel to the lymph node and the other parts of the body. So it is again through inhalation that the conidia come within the alveolar macrophages. They form the yeast, and here they will be multiplying, surviving within the phagolysosomes, and multiply and travel to different parts. So the most common presentation is pulmonary histoplasmosis that can be acute or chronic. So acute, it can present with hilar or mediastinal lymphadenopathy. Okay, so that can be hilar or mediastinal lymphadenopathy. Chronic, it can resemble a chronic cavitary tuberculosis. So that is where it can, be very similar to that. It can be seen in smokers with structural lung disease, and that will be characterized by upper lobe infiltrates and cavitation. See, these features are very suggestive of TB. So acute can present as hilar or mediastinal lymphadenopathy. Chronic can present like chronic cavitary TB with cavitation and upper lobe infiltrates. Then there are other manifestations also like mucocutaneous and disseminated. The lab diagnosis of histopathological examination with GIMSA stain and also an HND, you get tiny oval intracellular yeast cells with narrow based budding. Again, this description is very, very important. Oval intracellular yeast cells with narrow base budding. Now look at this image and try to recollect the other image. Actually, it is very hard to even see these, budding. So you can see these narrow based budding, okay, with an intracellular yeast. So, and that word intracellular yeast is very important. And that always points to histoplasmosis. Like, the person has an infection and the pathologist said that an intracellular yeast was found. Intracellular yeast form with narrow base budding is only seen in histoplasma capsulatum. Here also you can see the intracellular yeast. So they're very tiny. They're almost like spots. You very, very hard to make out. It's not the big ones that you get to see in the image. That is not the one. The spotted appearance that you get to see here and here, okay, that is the one actually. And it is a dimorphic fungus, which means that at 25 and 37 degrees centigrade, you will get the growth. So at 25 degrees Celsius, the mycelial forms will be seen, and at 37 degrees Celsius, you get the yeast form. And the mycelial forms have got tuberculate macroconidia, and these are the infected ones. So this is the tuberculate macroconidia. Okay, and the drug of choice is liposomal amphotericin B. Then another option was Coccidioides immitis. Coccidioides immitis will form spherules containing endospores. So here these are the spherules of Coccidioides immitis. So suppose you get a similar sounding question, and then this is the histopathological examination, then the answer would be Coccidioides immitis. Then Paracoccidioides brasiliensis was also an option that will show a pilot wheel or Mickey Mouse like appearance on GMS. Okay, pilot wheel or Mickey Mouse like appearance. So this is the Mickey Mouse. Okay, so now if you try to recollect, blastomyces dermatitis, B. So broad-based budding, figure of 8, double contoured cell wall, histoplasma on, that is on H&D, then histoplasma capsulatum, that will be showing narrow based budding, and it will be showing intracellular tiny oval cells, very, very small but intracellular. Coccidioides immitis spherules containing endospores, and Paracoccidioides brasiliensis GMS showing pilot's wheel or Mickey Mouse appearance. So, oops. Okay, pilot's wheel or Mickey Mouse appearance. Okay. And another thing I wanted to tell you was histoplasma capsulatum, a tuberculate macroconidia. That also you should not forget. This one. Okay, that also you should keep in. Then a 40-year-old farmer presents with a slowly enlarging, non-painful verrucous lesion on his right foot. The lesion started as a small papule several months ago after he sustained a minor injury while working barefoot in the fields. Over time, the lesion has grown and developed multiple raised nodules with black dots on the surface. The patient does not recollect any systemic symptoms. A biopsy of the lesion reveals sclerotic or medullary bodies. Which of the following is the most likely diagnosis? Sporotrichosis, chromoblastomycosis, mycetoma, or pheohypomycosis. Okay. So this is a verrucous lesion. As it is, the last sentence is directly pointing at the answer, but still, suppose it was not given, I would still want you to know this. So it's a verrucous lesion following a minor injury, okay, and then subsequently it became nodular. It's got black dots. That black dots is very important because that actually says that the melanin is there, okay. And no symptoms he recollects, and the biopsy result shows sclerotic or medullary bodies, which is classical of not sporotrichosis, not mycetoma, not pheohypomycosis. That one word is enough to diagnose it as chromoblastomycosis. So, chromoblastomycosis is a chronic subcutaneous mycosis. It's caused by dematiaceous or pheoid fungi, which are pigmented fungi due to the presence of melanin. And Fonsesia, Cladophylophora, Phyllophora, these are some of the causative organisms which cause chromoblastomycosis. There will be a slow-growing verrucous lesion with multiple raised nodules that is classical of chromoblastomycosis. And you get something called as sclerotic bodies, medullary bodies, muriform bodies, or copper penny bodies. All these names mean the same. And you will find these thick-walled, brown colored cells with multiple transverse septa. And this brown color is because of the presence of melanin. Okay. And this is the classical appearance. So this is you get this verrucous lesion with multiple nodules. And these are the sclerotic bodies. Okay, sclerotic bodies, medlar, muriform. Okay. Then sporotrichosis is again a pyogranulomatous condition that occurs along the distribution of the dermal lymphatics that's caused by Sporotrich schenki. Okay, and in that you will find something which is called as an asteroid body, not the muriform or the medlar bodies. Then mycetoma is a chronic granulomatous condition that's characterized by draining sinuses, grains, no sclerotic bodies there as well. Pheohypomycosis is a group of infections which are caused by pheoid or demeticious fungi. Okay, again there will be no sclerotic bodies and no verrucous lesions also. Okay. Then next question, a 35-year-old HIV positive man presents to the clinic with a 2-week history of fever, headache and confusion. His CD4 count is 50 cells per microliter and he has not been adherent to his antiretroviral therapy. A lumbar puncture is performed and the CSF sample shows elevated pressure and India ink stain reveals encapsulated E cells. Cryptococcal antigen testing of the CSF is positive. Which of the following is most appropriate initial treatment for this patient? Is it oral fluconazole alone or IV ampho B and oral flucytosine, oral itraconazole alone or IV voriconazole? Okay. So this is an HIV positive man and his CD4 count is 50. He has not been doing his ART properly. The CSF has been cultured and you're doing an India ink preparation which is showing encapsulated yeast cells and the cryptococcal antigen test is positive, which means that the organism is Cryptococcus neoformans. We are looking at a case of cryptococcal meningitis. What is the initial treatment for such a patient who is having cryptococcal meningitis? Do we just give only fluconazole or do we give ampho B with flucytosine or oral itraconazole or IV voriconazole? Okay, azole alone cannot be used for the treatment of a cryptococcal meningitis. It has to be IV amphotericin B and oral flucytosine. Okay, so let's use this question to look at this once again a little bit in detail. Cryptococcal neoformans meningitis is common in patients who have low CD4 counts, that is less than 200 CD4 counts, and HIV. So it's a capsulated budding yeast that is Cryptococcus neoformans. It's a primary CNS pathogen, but the mode of infection is inhalational via the lung through the blood to the CSF and to the CNS. And why the main virulence factors are the polysaccharide capsule and the production of melanin by the phenyl oxidase enzyme. And risk factors, of course, HIV with CD4 counts less than 200, hematological malignancies, bone marrow transplant, immunosuppressive therapy, patients who are on steroids, all this can be very, very important risk factors. And it's frequently seen in soil and in pigeon droppings. And the most common presentation, although we always talk about meningitis, the most common presentation is pulmonary cryptococcosis. And cryptococcal meningitis is more of a chronic meningitis with fever, headache, cranial nerve palsy, as well as loss of vision because of involvement of the optic nerve. And to diagnose it in the lab, the best thing to do is a negative staining of the CSF. You get to see these capsulated as modified India ink. You get the budding yeast cells with a refractile, clearly delineated space between the cell and the black background. So that is how you get to see the presence of this capsule. And that is usually helps to detect it in about 60 to 75% cases. Okay, so here you can typically see this capsulated budding yeast cell. So apart from the budding, just look at the, that space, that clear hollow space, which is classical of the presence of a capsule. Then gram staining won't reveal much. And another thing is that the yeast cells are round. Okay, that particular word, that is round budding yeast cells, that is very, very important, because for Candida it is oval budding yeast cells. So gram positive round budding yeast cells. When you can also use other stains to demonstrate capsule like Alcyon blue and 10% nigrosin, or musicarmine will demonstrate the cell wall, or you can use Mason's fontana to show the melanin, and gomori, methenamine, silver and PAS can also be used for tissue staining. So there are so many different stains that can be used. Remember Mason's fontana, remember nigrosin, okay, and musicarmine for the cell wall. Then antigen detection. Although the CSF, just by doing an India ink itself is 60 to 70% sensitive, but the best test would be the latex agglutination test of CSF or the serum. That is 90% is the sensitivity and specificity of that test. So latex agglutination test is good. If you culture it on BA, MA, CA and SD, you'll get the creamy colored yeast-like colonies. But for confirmation, you need to use the Niger seed or the birdseed agar, where you get these brown pigmented colonies because of the presence of melanin. Then there are other things that can be used like growth at 37 degrees centigrade, presence of positive urease test, mouse pathogenicity test, MALDI-TOF. All this can also be used for the confirmation of the diagnosis. Now, if it's a cryptococcosis without a CNS infection, then you can use azoles, okay? Whereas cryptococcosis with the CNS infection always calls for using amphotericin B with flucytosine followed by oral fluconazole. So, if it is without CNS, you can give fluconazole. Otherwise, you must give ampho B with flucytosine followed by oral fluconazole. Then, a 60-year-old man with a history of COPD presents with worsening of shortness of breath, cough and hemoptysis. A chest CT scan reveals a cavitary lesion on the right upper lobe with a fungal ball inside. A BAL is performed and a sample is sent for microscopic examination. Which of the following staining techniques is most appropriate for demonstrating Aspergillus species in tissue samples? Is it gram stain? Is it AFB stain? Is it PAS stain? Or is it a GMS stain? Okay. So here the features are there which is suggestive of an aspergillosis as a cavitary lesion with presence of the fungal ball, and the staining has to be done. Which one is the better one? So gram stain will not, will not adequately tell you whether it is a aspergillus or what, so that cannot be used, because in gram stain you might at the most just be able to see some fungal filaments, a little bit of hyphae, that will not help. Acid fast stain, no, aspergillus is not acid fast, there's no use of staining with acid fast. PA stain, yes, it does stain the fungal elements, but it's not very specific. It can also stain the glycogen, mucin and such other elements as well. But the gomori methenamine silver stain is excellent for visualizing the fungal components and excellent for seeing the fungal hyphae. Okay, and it will highlight and stain only the fungal elements, and they will be the ones that appear black against a green background. So you can clearly visualize the hyphae, black hyphae against a green background. That is classically seen with GMS. Okay, and gram stain only not very effective. At the most you might see some fungal hyphae. Acid fast no, PAS also, like I said, mucin and glycogen. So it is less specific. That is the reason why it is not preferred. A 35-year-old man presents to the clinic with a 2-week history of intermittent fever, chills and profuse sweating. He recently returned from a trip to a rural area in sub-Saharan Africa. On examination, he is found to be anemic and jaundiced. Blood smear analysis reveals ring-shaped trophozoites within RBCs. Which of the following is the most likely mode of transmission for the parasitic infection in this patient? Ingestion of contaminated food or water, bite from an infected Anopheles mosquito, direct skin penetration by larvae, fecal-oral transmission via contaminated hands. So this is a person with fever, chills, profuse sweating. He's been to sub-Saharan Africa. He's anemic. He's got jaundice. There are ring-shaped trophozoites within the RBCs. That is your biggest clue. And what is the most likely mode of transmission of infection in this patient? Do you think it's ingestion of contaminated food or water? This doesn't look like a GI infection at all. Okay, it's neither is it a fecal transmission. Then direct skin penetration while RVA does not present like this, but these ring trophozoites within the peripheral, within the RBC seen on a peripheral smear, we must be looking at malaria, and so it's bite from an infected Anopheles mosquito. Okay, so all these features are classical. So malaria is caused by Plasmodium species that is transmitted through the bite of the infected Anopheles mosquito. And the infective form to man is the sporozoites, which is present in the salivary gland of the mosquito, transmitted through the bite, or trophozoites and murozoites also, which can be transmitted during blood transfusion and vertically from mother to child. And for the mosquito, the infective form is gametocytes. Okay, so for mosquito, it is gametocytes, whereas for man, it is sporozoites. And the extrinsic incubation period is usually 1 to 4 weeks. And in Plasmodium malariae, the febrile paroxysm occurs every 4th day, that is after 72 hours, and it's called as the quartan malaria. Whereas for everything else, it occurs after the 3rd day. It occurs on the 3rd day, that is after 48 hours. It's 48-hour cycle, and it's called as a tertian malaria. So there's benign tertian and malignant tertian. Plasmodium falciparum is malignant tertian, and Vivax and ovale is benign tertian. So the febrile paroxysm occurs on the 4th day, that is quartan, and it occurs on the 3rd day, that is tertian. Okay, 4th day for malaria, tertian; for Vivax and ovale, benign; and for falciparum, malignant. Then contaminated food and water is not in this. It could be for giardiasis or amoebiasis. Direct skin penetration could be for hookworm or schistosomiasis, strongyloids. And fecal-oral transmission, that could be again for ascaris or enterobius. Then, a 25-year-old man presents to the emergency department with a 5-day history of severe abdominal pain, diarrhea, and tenesmus. He reports that his stools have been loose and occasionally contain blood and mucus. He recently returned from a trip to rural area in Central America. On physical examination, he is febrile and has got tenderness in the lower abdomen. A stool sample is sent for analysis, and an antigen detection test identifies Entamoeba histolytica. Which of the following is the most appropriate next step in managing this patient's condition? Administer metronidazole followed by a luminal agent such as paromomycin. Initiate supportive care with fluids and monitor for improvement. Perform a colonoscopy to assess the extent of colonic involvement. Prescribe broad spectrum antibiotics for bacterial enterocolitis. So again, this is a question that takes you for a full trip, right? Because he comes to you with a history of severe abdominal pain, diarrhea, tenesmus, loose stools. He's been to Central America, febrile, tender, but ultimately it's already diagnosed he's having Entamoeba histolytica. So what would you do for such a patient? Would you administer metronidazole followed by luminal agents such as paromomycin, or would you just be supportive care? Would you do a colonoscopy as a part of a management of this condition, or prescribe broad spectrum antibiotics for bacterial enterocolitis? So here, because it's diagnosed as Entamoeba histolytica, you must give metronidazole followed by paromomycin. Okay. So it is suggestive. So all this clinical history and presentation is very strongly suggestive of Entamoeba histolytica ascites, and it can cause Entamoeba histolytica colitis, not ascites. Okay, and it can cause amoebiasis. So it can cause amoebic colitis with dysentery and colonic ulceration. And you must give both metronidazole and tinidazole for the trophozoite, as well as idoquinol and paromomycin for the cyst, so that you can prevent the recurrence. So it's got both the trophozoite form and the cyst form. For the trophozoite, you must give metronidazole or tinidazole. For the cyst, it should be idoquinol or paromomycin, so that they can prevent the recurrence. Okay. And a few words about the trophozoite and the cyst. This hematophagous trophozoites, that is trophozoites which contain ingested RBCs, that is usually a sign of invasion, and that's pathognomonic of Entamoeba histolytica. And it usually indicates the presence of active infections. When you see trophozoites in freshly passed stool, it means that there is active infection. And on saline mount, you can see a 15 to 20 micrometer structure with a nucleus having a cartwheel appearance and active motility with pseudopodia. And again, like I said, this hematophagous trophozoite is a sign of invasion that is seen only in Entamoeba histolytica, not in coli, dispar, Bangladeshi, and all those things. So here you can see the ingested RBCs, and that is a pathognomonic sign of active infection. And when it's seen in freshly passed stools, it means that there is active infection. And the cysts are seen on iodine wet mount. It's got glycogen mass and chromatoidal bodies inside of that. Okay, and that's a tetranucleate, tetranucleate or quadrinucleate cyst. That is the one that is the infective form. The trophozoite is a replicative feeding form, whereas the cyst is the infective form. Okay, does this look as if I cut the thing? No, I'm trying to say it's very, very important. Then histologically, PAS and H&E, they will normally reveal the presence of trophozoites. Here you can see the trophozoites here on the PAS stain. Then stool cultures, you can have polycenic or exenic media. Then stool antigen test, that is 170 kDa antigen ELISA. That is coproantigen test ELISA. That is usually helps to differentiate between histolytica and dispar. Then you can also have the serology, that is you can do the amoebic antigen detection or antibody detection. And there's something called as a zymodyne analysis or the isoenzyme analysis, which is again differentiates histolytica from dispar. So serology, you can have stool antigen detection, you can have serology, that is amoebic antigen or antibody detection, zymodyne analysis. Okay, then molecular tests are also there. So supportive care alone will not be enough. Just by doing a colonoscopy, what you can do is at the most you can diagnose it better, but nothing more than that. You need to manage the condition also. And why would you give broad spectrum antibiotics for something that is not a bacterial infection? A 30-year-old man who recently returned from a trip to a rural area in South Asia presents to the clinic with a history of intermittent fever, weight loss, and darkening of skin. He also reports night sweats and progressive fatigue. Physical examination reveals splenomegaly and hepatomegaly. A bone marrow aspirate is performed, and the presence of amastigotes within macrophages confirm the diagnosis of visceral leishmaniasis. Which of the following is the primary mode of transmission for the nocturnal behavior of the leishmanial parasite that causes this disease? So how does the parasite transmit the disease? That is the question. They have complicated it so much. They've given you the patient's clinical condition, a lot about the symptoms and the signs that were elicited. Then the lab diagnosis was done by a bone marrow aspirate, and that revealed the presence of amastigote form within the macrophages. Okay, that confirms the diagnosis of visceral leishmaniasis. So which is the primary mode of transmission for the nocturnal behavior of the leishmania parasite? So is it bite from an infected Aedes mosquito, bite from an infected sandfly during night time, contaminated food and water ingestion, or direct contact with infected blood? So the mode of transmission of Leishmania donovani, which is a pathogen, is by means of a particular vector that causes bite, and that bites at night time, that is infected sandfly. It's not Aedes mosquito, it's got nothing to do with leishmaniasis. Contaminated food and water and direct contact with infected blood are also not methods of transmission of leishmania usually. Okay, that's not the method of transmission of leishmania. So leishmania are obligate intracellular pathogen, and it's usually by the bite of the sandfly vector of either Phlebotomus or the Lutzomia genus. Okay, they are nocturnal agents. They'll be biting more during the night time. And this I've seen a question wherein they've just given this image and asked to identify the vector. This is the female sandfly. Don't think it is a mosquito or something. No, it's a sandfly vector only. Okay, so these are hemoflagellates. They'll affect mainly the reticuloendothelial system of the host. And there are two main forms, that is the amastigote form and the promastigote form. Amastigote form is diagnostic form that is seen in man, whereas the pro-mastigote form is the infective form to man, that is the one that is seen in the sandfly. So amastigote form is diagnostic and the pro-mastigote form is the infective form to man. So visceral leishmaniasis has got a pentad of symptoms characterized by fever, weight loss, hepatosplenomegaly, hypergammaglobulinemia and pancytopenia. Okay, this is the pentad of symptoms that you get to see in visceral leishmaniasis. Fever, weight loss, hepatosplenomegaly, pancytopenia, hypergammaglobulinemia. There's something called as post-Kala-Azar dermal leishmaniasis or PKDL that occurs a few months to years after visceral leishmaniasis in 2 to 50%, okay, of patients who get treated with antimalarial. So there's a PKDL that is occurs in 2 to 50% of the patients once they are treated with antimalarials. Okay. So this is an example of PKDL. This is how it appears. This image that you get to see here. Then life cycle of Leishmania donovani is what happens when the sandfly bites us. The promastigotes from the foregut of the sandfly, the salivary glands that will enter into our skin. Okay, and in the skin, within the skin macrophages itself, it is transforming into the amastigote form, and this is carried by the blood to the reticular endothelial system, where it is getting replicated, and this is again converted. This amastigote form is fed upon by the sandfly when it bites, and this amastigote form transforms into promastigote in the gut and again comes back into the salivary gland to bite the next human being. So the infective form to man is promastigote, the infective form to the sandfly is the amastigote form, the diagnostic form in man is also the amastigote form. Okay. So lab diagnosis of visceral leishmaniasis, microscopy, there is the GMSA staining, okay, that when you do the GMSA staining, you detect the Leishmania donovani bodies or the LD bodies, which are nothing but macrophages which contain the amastigote forms within them. So they're filled with amastigote form. And the best sample would be splenic aspirate, but the most commonly done is bone marrow aspiration. Lymph node and aspiration and liver biopsy can also be done. So splenic, liver, hepatosplenomegaly, right? So spleen, liver can be done, of which spleen is the most sensitive, but bone marrow and lymph node is also done. And this is a pictorial representation of how it appears. This is a macrophage with the nucleus being completely pushed to one side. Can you see here? And numerous amastigote forms will be seen filling the macrophages, called as the LD bodies, detected by the GMSA staining. And culture usually detects the promastigote form, and that is useful in drug sensitivity testing and identification. And the common media that is used is the NNN media and the Schneider's liquid media. Then you've got antigen and antibody detection. Antibody detection is done in the serum using ELISA or indirect fluorescent antibody technique or direct agglutination testing. And ICT uses RK39 and RKE16 antigens as well. Then you've also got the antigen detection. So this is the antibody detection, that is ELISA and ICT. Then antigen detection is carbohydrate antigen can be detected in urine by latex agglutination testing. Molecular techniques can also be used. PCR can be used to detect the specific kinetoplast, that is the DNA, that can be done by molecular testing. Then other test is Leishmanin test or the Montenegro test that shows the delayed type of hypersensitivity in those with good cell-mediated immunity. And this is usually positive for all excepting active visceral leishmaniasis and diffuse cutaneous leishmaniasis. Animal inoculation can be done in golden hamster. Okay, that can be used. Then there are some non-specific tests for hypergammaglobulinemia like Napier's aldehyde and Chopra's antimony tests. And liposomal amphotericin B is the current drug of choice, but previously antimalarials used to be used. However, now there is resistance. Also, other drugs like miltefosine and paromomycin also have a role in treatment of leishmania. So, leishmania, what are the clinical symptoms? How do you diagnose it in the lab? Gene sustaining LD body is very important. What are the culture media? You've got antigen detection, antibody detection techniques is there. Okay, then you've got molecular methods as well for the diagnosis. Some other non-specific tests. A Montenegro test or the Leishmanin test is there. Okay. So one thing I wanted to tell you here is, so everything that I have circled, they're all different diagnostic. Antigen detection, molecular, Leishmanin, animal inoculation. Okay. Then non-specific tests, all these. Then Aedes is not for leishmaniasis. Contaminated food and water is not for leishmaniasis. Direct contact with infected blood is not a primary method, but rarely alone it can be seen. You don't even have to remember that. You leave that out. It is not for leishmaniasis. Okay. Then the next question. A 25-year-old man presents to the clinic with a 5-day history of fever, chills, and headaches. He recently returned from a trip to a malaria endemic region in Africa. On examination, he is febrile and pale. A blood smear is performed and the following image is obtained. Okay, so here you can see a peripheral smear, a Giemsa stain smear you can see here. And what do you get to see here? So based on the blood smear findings, which stage of the Plasmodium life cycle is most likely present and which species is most likely responsible? So here you can see multiple ring forms. You can also see that headset or the headphone type of forms which like broken open-ended rings. Okay, you can see some of them here. And you can also see this crescent shaped or banana shaped gametocyte. So it's so classical, isn't it? Is it the Schizon stage of Plasmodium vivax? No. Is it the trophozoid stage of Plasmodium falciparum? Yes, it is the trophozoid stage and the gametocyte stage also. It's not the merozoid stage of Plasmodium malaria. Merozoids are not seen in peripheral blood. And it's not the gametocyte stage of Plasmodium ovale. It does not look like this. Okay. So ring-shaped trophozoids and crescent-shaped gametocytes are classical. Then what are the types of peripheral blood smears you can get to see? There are thick and thin smears are there. And the different stains that we can use is Leishman's, Giemsa, Wright's, JSB, Field. So many different named staining techniques are there. Thick smear and thin smear. Thick smear is to detect the parasite, to know the degree of parasitemia and for looking for pigment production. Whereas thin smears have got more to do with speciation. Okay, so to detect parasites, actually thick smears are more sensitive. 5 to 10 parasites per microliter of blood can be detected. Now this is just a pictorial representation of the different types of appearances of early trophozoite, late trophozoite, schizont, male and female gametocyte. So vivax, falciparum, malaria and ovale. So the RBCs are slightly enlarged in vivax and ovale if you can have a look at it. Okay, only thing is ovale is more oval. And the early trophozoite forms, okay, that will be seen as a ring form and it usually occupies about 1/3 of the RBCs in case of vivax. And the late trophozoite form is more of an amoeboid sort of structure for vivax. And the merozoites contains about, the schizon contains about 12 to 24 merozoites. And the male and female gametocytes are almost the same for vivax, ovale and malaria. They'll be all round and they will not be seen outside, extending outside the cell. Now, regarding the early trophozoite, both vivax, malaria and ovale are similar. They've got these ring forms as early trophozoites. Only thing is ovale is more a fimbriated, oval sort of a structure. The late trophozoite is amoeboid for vivax, but for malaria, it's more of a band form. So you can see it's written here band form and this will be fimbriated. Okay. Then regarding this, this late trophozoite form, that is this as well as this, will not be seen in the peripheral blood because the late trophozoite and the schizon stages of Plasmodium falciparum occur deep in the capillaries of the brain and the internal organs. So that will not be seen in the peripheral blood only. So there will be no such a form to be seen. That is late trophozoite and schizon. So don't need to remember that. Then for malaria and vivax, it's usually 4 to 8 merozoites, okay, in the schizon stage. And regarding the gametocytes, it's very obvious. All of them are more or less similar, excepting these two. That is a male and female gametocyte of falciparum, which looks like a crescentic shape or a banana shaped gametocyte. So that alone is unique, okay. Then the RBC size is normal for malaria and for falciparum, but for vivax and ovale it is enlarged. And ovale of course is fimbriated, and old erythrocytes, mature ones, are preferred by malaria. Pigment is dark brown for all excepting for vivax when it is yellowish brown, and only ring forms and gametocytes are seen in falciparum in the peripheral blood. The reason for that also we have already discussed. Then merozoites will not be seen in the peripheral blood, we said. and gametocyte does not have that shape, so now all the other options are ruled out. Okay, then I'll just take a 2-minute break. Coming to the next question, a 28-year-old pregnant woman presents to her obstetrician for a routine checkup. She reports that she recently adopted a stray cat and has been cleaning its litter box. The physician is concerned about the risk of Toxoplasma gondii infection and orders serological testing. The lab result shows positive IgG antibodies and negative IgM antibodies for Toxoplasma gondii. Which one of the following is the most appropriate interpretation of these results? acute infection with Toxoplasma gondii, past infection with Toxoplasma and immunity, no infection with Toxoplasma gondii, reinfection or reactivation of Toxoplasma gondii infection. Okay. So this here, the person has a history of contact and there is IgG but no IgM. So it is because there is no IgM, it is not acute infection with Toxoplasma gondii. Okay. And if there is no infection, there should not have been either IgG or IgM both, but there is IgG. Reinfection or reactivation means that there should have been some IgM at least could have been there, because there is a fresh infection that's happening, or there's a reactivation of Toxoplasma gondii infection. So here this only IgG alone means that there is a past infection with Toxoplasma and immunity. Okay, so let's look at it in detail. So the presence of a positive IgG and negative IgM shows that there is a past infection, but not something that has happened now. So the absence of IgM indicates that there is no current or recent. So there is no reactivation or reinfection, that is also not there. And there is no acute infection also, both that is also not there. But an IgG alone shows past infection and subsequent immunity. So how do you diagnose toxoplasmosis? Okay, direct microscopy can be done on peripheral blood, on body fluids, lymph node aspirates, bone marrow aspiration, biopsy. All this can be subjected to GIMSA, HND or PAS staining. So these are the stainings that can be done. And there are biological forms, that's the tachyzoids, the tissue cyst, as well as the oocyst. Okay, and these tachyzoids, they are rapidly multiplying forms. They are crescent, they are almost like crescent shaped. Okay, suddenly I was wondering whether that is for something else. So that is a crescent shaped. Okay, crescent shaped tachyzoids. These are the rapidly multiplying forms, and these are seen in peripheral blood. Then you've got the tissue cysts, which contain the bradyzoids. These are the slowly multiplying forms or even the resting forms that are seen in muscle and brain, and they are intensely PAS positive. So this is the tissue cyst with bradyzoids. They are seen in the body. And you can also do antibody detection. So antibody detection is capture ELISA can be done for acute IgM, IgA or fourfold rise in IgG should be shown. Whereas for congenital toxoplasmosis, it's IgM or IgA. So when you do an antibody, remember if it's acute, it's IgM, IgA or fourfold rise in IgG. And for congenital, there is no IgG, it's IgM or IgA. The Sabin-Feldman test is a gold standard test for congenital toxoplasmosis, and that is usually done in reference laboratories. But that test does not differentiate between IgG versus IgM. Molecular diagnosis by PCR is also possible. Besides this, you can also have antigen detection, animal inoculation, tissue culture. So many other different methods of diagnosis is there. And the one unique feature of toxoplasma is that all the three morphological forms can transmit infection. So we already discussed tachyzoids and tissue cyst, and oocyst is the sexual form. It consists of two sporocysts with four sporozoites each. Okay, so the sexual form, which is usually seen in cats and other felines, is the oocyst, and it contains two sporocysts with four sporozoites. Okay. So this is just a representation of that. So here you can see the crescentic tachyzoids, and this is the bradyzoids, and this is the sporozoids. And mode of infection could be either consumption of undercooked meat, that is the most common mode of infection, or through contaminated food and water of the oocyst, or it could also be through blood transfusion or transplacentally, that is by means of the tachyzoid. So that's how all the three are involved in causing the infection. And remember that cats are the definitive host. Okay, that's a sexual cycle or the feline cycle, whereas man is an intermediate host, as are rats. Okay, and human infection is usually a dead end infection. So when you think of the lab diagnosis, you can think of how to demonstrate this. GM sustaining HND and PA, so it's a tissue demonstration mainly. Then you've got antibody detection, whether it's congenital, whether it's acute, Sabin-Feldman test is there. Then you've also got antigen detection and many other methods. Molecular diagnosis is also possible. And you must remember that the unique feature of this is that all the three are capable of transmitting infections, all the three morphological forms. Okay. So acute infection would be indicative of positive IgM. Then no infection means both would not be there. If it's a reinfection or reactivation, it can either show IgM or it should show a serially rising IgG titers, but that's normally not seen in immunocompetent. That's something that is seen in immunocompromised individuals. Okay. Then, a 35-year-old man presented with chronic swelling in his left leg, which has progressively worsened over the past year. He also reports episodes of fever and feeling of heaviness in the leg. The patient recently returned from a long-term stay in a rural area of Southeast Asia. Physical examination reveals significant lymphedema of the left leg. The physician suspects lymphatic filariasis caused by Buscheriria bancrofti. Which of the following diagnostic tests is most appropriate to confirm the condition? Is it a daytime blood smear, a nocturnal blood smear, stool examination for ova and parasites, or a skin snip biopsy? So here again they've given clinical features that suggest of filariasis, and the clinician himself suspects that it's Buscheriria bancrofti filariasis. And what is the best thing to do? So to diagnose Buscheriria bancrofti filariasis, you have to take, is it daytime or nocturnal blood smear? Because anyway, one of the answers have to be wrong. It is a nocturnal blood smear examination that has to be done, not a daytime one. Okay. So symptoms, travel to an endemic area, all that is suggestive, and you need to do a nocturnal blood smear. So nocturnal blood smear, because the periodicity, okay, it is nocturnal, that is it peaking it at night between 9 p.m. to 4 a.m. That is classical of Buscheriria and Brugia. Whereas the diurnal periodicity, that is peaking between 12 to 2 p.m. That is at midday, that is classically seen in loa. Then there's subperiodic, that is diurnal subperiodic and nocturnal subperiodic. Diurnal subperiodic means it's peaking between 3 to 5 p.m. whereas between 7 to 9 p.m. is nocturnal subperiodic. So subperiodic is something that's seen in Buscheriria, that is transmitted through the Aedes mosquito, and there is no periodicity, that is this is not there for Manzanella and Onchocerca, so non-periodic. So nocturnal Buscheriria and Brugia, diurnal loa, subperiodic Buscheriria transmitted through Aedes, and no periodicity for Manzanella and Onchocerca. So lymphatic filariasis is caused by Buscheriria bancrofti, Brugia malai and Brugia timori, of which 90% cases are through Buscheriria bancrofti and the rest is through Brugia. And the vector is everything other than Manzanites, that is Anopheles, Culex and Aedes. All of them can be vectors. There are two morphological states, that's the adult form and the larval form, and the larval form has got 4 stages, of which microfilaria, that is the first stage larva, is a diagnostic form that is seen in blood. It will be molting twice to form the third stage of the filariform larva, which is normally the infective form. So the filariform larva is the infective form. And like we said, microfilaria is the diagnostic form mainly for lymphatic filariasis, but not for occult filariasis. You can't see it in occult filariasis. And it's got nocturnal periodicity, so normally it is seen only during night. But if you give a DEC provocation test, that is 30 minutes after DEC intake, if you collect the sample, then microfilaria can be seen in peripheral blood even during daytime. Okay, so that is the importance of a DEC provocation test. So lab diagnosis, you can demonstrate microfilaria by either thick or thin smear. You can do a James stain or a quantitative Buffy coat method, and blood is usually collected at night, but during day also it can be collected. Now both these microfilaria, Buscheriria and Brugia, they have certain differences. Okay, that is Buscheriria has got a pointed tail tip, it's got discrete nuclei, it's graceful and sweeping curves are seen, and even though the tip is pointed, nuclei are not seen up the tail tip. The tail tip is free of nuclei. Okay, and the cephalic space length is to breadth is 1:1. Okay, and the nuclei are discrete. So you can make out that they are discrete. Okay. Whereas Brugia malai has got a blunt tail tip with 2 distinct nuclei there. Okay, up to the tail tip. This is blunt. And the cephalic space, the length is to breadth is 2:1. And here you can't make out because there's overlapping nuclei here and there is kinking with secondary curve. So these are some of the difference between the two. Then you can have antigen detection method, that is ELISA or ICT, using monoclonal antibody to OG4C3 and AD12 antigen. You have to remember the names of these antigens. And antibody detection using a flow-through assay using Buchereria-Bancrofti, that is WB6SP1 and WB123 antigen, that's luciferase. Okay, so you can do an antigen detection with OG and AD, and or an antibody detection with WB6SP1 and luciferase. Then you can also do imaging. Finereal dance sign can be seen on ultrasound. You can do a real-time PCR, and non-specific tests like eosinophilia and elevated IgE can also be done. Skin snip technique is actually done for onchocervica volvulus, the one that causes river blindness. It is not for this. So that is why the most appropriate test in this condition would be a nocturnal blood smear. So remember that how to take the sample, what are the different forms, how to diagnose microfilaria on peripheral smear, what are the antigen detection tests, antibody detection tests, molecular tests, non-specific tests, okay? All these you have to remember. Then, a 65-year-old woman is admitted to the hospital for management of a complicated UTI. During her hospital stay, she develops fever, productive cough, and shortness of breath. A chest X-ray reveals a new infiltrate in the right lower lobe. Sputum cultures grow Pseudomonas aeruginosa. The patient has been on broad-spectrum antibiotics since admission. Which of the following is the most likely risk factor that contributed to this patient's hospital-acquired infection? Is it a prolonged use of urinary catheter, recent surgery, prolonged use of mechanical ventilation, or an immunosuppressive therapy? So here in this question, I felt that maybe something is missing, because they said that she is admitted for a complicated UTI, and during her stay, she developed fever, cough, shortness of breath. X-ray showed this, and lower zone new infiltrate, and sputum cultures with Pseudomonas, but nothing is mentioned about her ventilation. But we have to assume that if this is a healthcare associated infection, she has to have been intubated. Okay, the prolonged use of urinary catheter would have caused a catheter associated urinary tract infection. A recent surgery would have caused her a surgical site infection. Okay, an immunosuppressive therapy would cause some other opportunistic infection, but it's only by a prolonged use of mechanical ventilation that she could have acquired a hospital acquired infection of the respiratory tract. Okay. So new onset fever, infiltrate with Pseudomonas should suggest that she has a VAP. And how she got a VAP? She was on the ventilator. And Pseudomonas is a very common agent which causes VAP. So especially those who have been on a mechanical ventilation for an extended period of time. Okay. And like I mentioned about urinary catheter and surgery, that has already been said. Whereas immunosuppressive therapy can lead to various infections. But here the specific scenario with Pseudomonas should make you think of mechanical ventilation. So anything that is prolonged mechanical ventilation can lead to VAP. Prolonged use of catheter can lead to COTI. Prolonged and improper management of central line can lead to clepsy and surgical site infections. So these are the 4 healthcare associated infections for which surveillance is also continuous and ongoing. Okay. Then coming to the last question before we take a break. A 32-year-old nurse working in a hospital is responsible for disposing of a biomedical waste generated in the emergency department. She needs to correctly segregate the waste according to the hospital's biomedical waste management protocol. Among the waste materials are used syringes, blood-soaked dressings, unused medications, and non-contaminated plastic packaging. Which of the following types of waste should be disposed in the red colored bin according to the BMW guidelines? Used syringes, blood-soaked dressings, non-contaminated plastic packaging, and unused medication. So here you have to know the biomedical waste management policy. There are 2 main categories, that is red and yellow for biohazardous waste. And it's easy to remember that red is always for plastics, non-biodegradable, and yellow is always for biodegradable. So what can be used, which type of waste should be disposed in the red colored bin? That should be a plastic waste. So used syringes, yes, that can be discarded in the red colored bin. Blood-soaked dressings, that is biodegradable and that is biohazardous, so that should go into the yellow colored bin. Non-contaminated plastic packaging is like general waste, so that can go into the black colored bin, and unused medications that can again go into a yellow colored separate cover, not the one in which you're going to be putting the blood soaked dressings. Okay. So other items that will go into the red colored would be IV tubings or urinary catheters, blood bags, not blood bags, sorry, urine bags, and all those things will be going into the red colored bin. That can be disinfected and recycled. Okay, so that can be recycled and used. Then yellow colored bins is blood soaked dressings, human tissue, microbiological laboratory waste, plaster of Paris, of course, blood bags, all of these can go into the yellow colored. Black color is for general waste, and separate bin for discarded or expired medicines, separate one for cytotoxic drugs. Then for glassware, you can have a blue bin, okay, to dispose of these ampules and vials and slides. And for sharps, you've got the puncture proof, leak proof, and tamper proof sharp containers, okay, the white colored sharp containers. So this is a quick gist of the biomedical waste, and proper disposal of biomedical waste is something which has to be done and is the responsibility of the staff who is using it. So these are in a nutshell, we have covered all the important areas across the subject of microbiology, including systemic bacteriology, parasitology, mycology. So we have quickly gone through the different areas and virology, and I hope that this is useful for your revision.